హలో హలో కొంచెం వాయిస్ తక్కువ వాయిస్ ఎక్కువ ఉన్నది. హలో 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 కరెక్ట్గా ఓపెన్ చేయి బ్రో ఫస్ట్ అంతా డిలీట్ చేయి ఇది డిలీట్ చేయాలి. ఇట్లా కాదు స్వామి, ఇదంతా తీసేయి. హిస్టరీ లాగా ఉంటే ఫోటో రాదు కదా. ఏదానికైనా సౌండ్ తక్కువ పెట్టుకోవాలి. ఇది నువ్వు పంపించుకున్నావు కదా. హలో హలో మైక్ టెస్టింగ్. హలో స్పీకర్ సౌండ్ చూడు. హలో 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 మైక్ టెస్టింగ్. హలో 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 చెక్ 1 2 3. హలో హలో చెక్ చెక్. ఆడికి చేంజ్ కాదు కెమెరా యాంగిల్, ఇదే చేంజ్ చేయాలి. కట్టుకొడితే అది ఇది చేంజ్ అవుతుంది. హలో 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 మైక్ టెస్టింగ్. ఇది వస్తుందా కెమెరా చూడు. ఏ కెమెరా చూపిస్తుంది? ఆడియన్స్దా ఇదా? ఈడ చేంజ్ చేయాలి, కట్టు కొట్టాలి. ఎప్పుడైతే అది ఇది చేంజ్ చేయాలి, అందులో కొడితే రాదు. అర్థమైంది కదా. హలో 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 టెస్ట్ 1 2 3. ఆడియన్స్ పెడుతున్నాను. టైం తీసుకొని ఆడుకో. నేను ఆడియన్స్ హలో చెక్ 1 2 3. హలో హలో రిఫ్రెష్లు ఉన్నాయి కదా బండ్ల. ఆడియన్స్ ఉన్నాయి కదా. ఓవరాల్ పెట్టు. పైకి కొంచెం పైకి. సో ఎప్పుడైతే నువ్వు ఆడియన్స్ చూపించాలనుకుంటే ఆడ కట్టుకొట్టాలి. మళ్ళీ ఇది చూపించాలంటే కట్టు. ఇది పని చేయదు, ఓన్లీ టీమ్స్కే పని చేస్తుంది. వస్తుంది కదా వాయిస్. హలో హలో
అదే వాల్పేపర్ పెడితే ఫ్రీజ్ చేసి పెడదాం అనుకున్నాను. ఫ్రీజ్ చేసి
మనం ఆన్ చేసి పెట్టలేము అనుకో.
Hello. Students who have not registered yet, please complete your registrations at registration desk, please, in front of this lobby. Yeah. Mm.
I request all the dignitaries and the delegates to come inside the hall. A very good morning to everyone. On this lovely Sunday morning, I welcome all of you to this beautiful and lovely Continental Hospitals to look back at the journey of Orthopedics department for the last year. As we look back, we reimagine the experience of the journey we have done in management of complex traumas and multidimensional joint replacement surgeries. And what a stellar year it has been, with outstanding outcomes, path-breaking initiatives, and momentous achievements in the form of the smiles and satisfactions of our patients when they had no hope or very little hope of complete recovery. Today, we do not just recall and reminisce the last year, but also look ahead, forward for new challenges and new milestones to achieve. I once again extend my heartfelt welcome to all of you, to the chairman of Continental Hospitals, Dr. Guru N. Reddy sir, to the director of Continental Hospitals, Dr. Raghu N. Reddy sir, program director Dr. Gautam Chaudhary sir, to all the senior consultants and consultants of Orthopedics department and the other departments, to the delegates, to my colleagues, friends, and all. Now, without waiting, I would like the honor to call Dr. Guru N. Reddy sir to give us the welcome note, opening note, and the guidance. Thank you.
Good morning, Dr. Sheikh. I think this is a wonderful introduction. Good morning, consultants, my colleagues, and registrars, all the audience here. I think some of you are doctors, perhaps, and most of you are physiotherapists, I was told. Wonderful Sunday morning for you to listen to our consultants and their journey through the past year. Now, just a few things I want to highlight. At Continental Hospitals, the Department of Orthopedics and Joint Reconstruction, which was established back in 2013, our journey has been very phenomenal. When you compare and contrast to the rest of the facilities, what I feel proud coming from the United States, spending for almost 4 decades, that the principles of surgery, the methods that doctors adopt, their approach to the patients and the patient care, and looking into, what are the new therapies that are coming and how we can offer to the patients. So we had truly a wonderful experience with our orthopedic consultants throughout, and particularly this past 2 years has been extraordinarily exciting. We have several members in the department, as all of you know. You might have seen our website, and this session also happened about 6 to 8 weeks back. What makes a great department, what brings people together, is the diversity amongst the consultants. When each one specializes in one particular thing and aspect, and they can bring it to the patient in a collaborative manner, and ultimately the patient benefits, who will have a successful journey. So that is important. No single person is an island in himself, and practicing independently without associating with their colleagues in a department, which exists, sometimes, that may not fulfill, everything that we would like to give to the patient. So something you all have to learn, that if you're not practicing, I would like to emphasize on that fact. Collaborative care in medicine is extraordinarily important. In fact, Charles Mayo is one of the things I keep telling. As a matter of fact, 2 days ago, I was on a Zoom call with Dr. John Kiesel. You can all Google him, for about an hour at the Mayo Clinic. He is a pioneer in the world of preventive oncology and inflammatory bowel disease. We're going to have a Mayo Clinic session next year, which are working on that on a very large scale. Anyhow, given that, Charles Mayo basically said that medicine is a cooperative science. You can't independently, no single person is tall enough to be independent of the others. So remember that, as medicine is advancing so much, new things keep coming. And for any one of us, in wherever we are working, whether you're in management, whether you're a physiotherapist, whether you're a cardiologist, does not matter. Reach out to your colleagues at the end of the day and see what is that he or she is thinking so that you can, collectively give the best to the patients. Now, we all know what a physiotherapist is. Most of your physiotherapists, the origin of the word physiotherapy is from the Greek language. It comes from physio, which is nature, and therapy is healing. So this was a Greek contribution to this word. So basically, nature should heal. That was the concept of physiotherapy, and then subsequently it was Lorenz Gleisch from Germany who, for the first time, used the word physiotherapy, therapy spelled as T-H-E-R-A-P-I-E, not P-Y. So he was Lorenz Gleisch about 106 years ago, 106 years before my birth. So now you can guess how old I am. So I'm not going to declare my year. So it was the first time Gleisch introduced the word physiotherapy, but they say that in 1813, prior to whom was a Swedish doctor who emphasized on, was the first one who actually helped manipulation and exercises in terms of emphasizing on physiotherapy. Just one last couple, a few things that I want to highlight. Today what I see is, sometimes it's very painful, that orthopedic surgeons have been reduced to basically like carpenters. The perception of the public, the perception of the other colleagues, they're just fit to do only some joint replacement, make a few lakhs or crores, and and that's all the end all and be all of it. It's a shame. What these guys went to school, their capabilities of doing, the number of bones that a human skeleton, a human body has, the number of joints that needs to be taken care of, the vastness of this subject, unfortunately, has been reduced, to a perception of just some joint replacements. And the reason I say that, every other month we see in the papers a new joint center popping up. I think they're faster pacing than McDonald's, that opened in America at the end of the day. So probably there'll be one in my lane too, where they'll open a joint center. So what the message I'm trying to deliver, okay, you have to be very careful, when you're recommending your patients, when you're choosing your doctors at the end of the day, what is their caliber, what is their potential, what is their approach, how they're really are these everyone jumping on and doing a joint replacement? Are they focusing on preventive strategies? Are they focusing on emerging, therapies? We will not have joint replacement 10 years from now, the way in which science is advancing. The biological and molecular biology that is enhancing, the cellular therapies that is coming into place, the gene therapy that is happening. There's a beautiful article which I was reading on the other day from Oxford Academic. It wonderfully summarizes, published in May, beautifully summarizes what is coming up in terms of the gene therapy and where things are at this point in time. So that is what the doctors here at Continental, they do stem cell therapy where it's indicated. They use PYP where it is indicated. So being abreast of cutting edge technologies and giving best to the patient is very important. Then comes trauma. Every person who has a traumatic injury, who fractures his bones or fractures his joints, hips, and all of those things, the approach to trauma is extraordinarily crucial. It requires great talent. It requires, different approaches to take for the patient, because the goal there is that to optimize the function of the patient. It's not just putting some rods and screws and send him out. Unfortunately, that's a tragedy. Then that patient is going to limp for the rest of his life. He's going to have crooked limbs, and he'll never get better. I think I'm very proud of the team, what it does, and particularly with the Elizarov procedure, which Dr. Gautam has popularized, which I only read it in the medical school or something like that. But here I read it now every week at the end of the day. So it requires patience, it requires commitment, and it requires that goal. You can always fix it in an hour and a half and walk out from the operation theater and collect the same money, correct? Why should I bust my back or bust my butt at the end of the day, sorry for my French, and sit there for 5 to 6 hours and try to do something to the patient with the objective that you're going to give them good locomotion and you're going to have a great outcome. So I think with these words, what I want to lastly emphasize is take this message understand this. Collaborative care is extremely important, and what you're seeing or what you're going to be seeing today is all these doctors, some of their very interesting cases, what they have done in this past year. They're going to showcase them. Dr. Sudhakar Reddy is not here. He's celebrating his 50th birthday. He came to my office yesterday. His wife has given him a little surprise, I guess. So let him celebrate his 50th birthday. One of his other associate colleagues is going to review his cases. With that, this thing, Gautam, thanks for organizing this, and go ahead with your scientific session. Thank you.
Thank you so much, sir, for your guidance. Now, without waiting, we'll start our journey of the last year of the orthopedics. I'll hand over the mic to our program director, Dr. Gautam, sir. He'll lead the way. Thank you, sir.
Ladies and gentlemen, good morning. Sir, I would like to tell you a few things. You are a walking encyclopedia because you can talk on any subject. And truly, I will tell you, it is not boasting you or anything. I have a passion. That passion also comes whoever sitting on the top seat. Always do something great, something great. That's what I told my Chakri, who supports me always, my colleague, dear colleague. We should, everybody, because our acquaintance is 22 years. That's openly I'm telling you. The thing is, we need to do something different. That's what I told Arun. Present a case which is different. Don't present hip replacement, knee replacement, rod screw. Something different we should do. And that thing we got. I have a passion, but you ignite the passion. That is the important thing. And another beautiful thing is, on top chair, someone who is well educated, who knows what he is doing, is having a blessing to the institute, not some thug or somebody sitting there and just doing that. One thing I would like to tell you honestly, I was afraid to come to this corporate hospital because my friends told you are finished, you can't do any of that, but I'm telling you, I'm very happy. I'm working as if I'm working in Indo-British because freedom is there. We all doing what we want, honestly talking to the patient, I'm very happy. Thanks for that. Thank you very much. Good morning. I stand before you today with a sense of immense gratitude and pride as I reflect upon the incredible journey that the past year has been here at Continental Hospital. It's been a year filled with challenges, learnings, and remarkable moments in the world of medicine and surgery. First and foremost, I was to express my deep appreciation for the unwavering support of my colleagues, the exceptional nursing staff, and the entire healthcare team here at Continental Hospital. Without their dedication and teamwork, none of the accomplishments I am about to showcase today would have been possible. Over the past year, I have had the privilege of operating on a diverse array of cases, each with its unique complexities and intricacies. From treating the aftermath of traumatic accidents and even performing revision replacement surgeries, it has been a journey that has tested my skills and knowledge every day. But what truly sets this experience apart is the spirit of resilience and hope that I have witnessed in every patient, their trust in our team, their courage in the face of adversity, and their determination to regain their health and well-being are the driving forces behind our relentless pursuit of excellence. Today I have the honor of presenting to you a selection of cases that have not only challenged us, but have also highlighted the power of modern medicine and the collaborative efforts of our entire medical team. Each case represents a testament to our commitment to delivering the best possible care to our patients. As we delve into these cases, I encourage you all to not only appreciate the medical advancements, but also the human stories that lie behind each surgery. Our patients are not just cases, they are individuals with dreams, families, and a profound desire for better quality of life. I hope that by the end of this presentation, you will gain insight into the challenges we have faced, the innovations we have embraced, and the outcomes we have achieved together as a team. I am excited to share these experiences with you, and I'm equally eager to continue our journey towards marking a positive impact on the lives of our patients. Thank you for joining us today, and I look forward to an engaging and enlightening session as we discuss the collective efforts of our entire team in the past year. Thank you very much. We'll start. This is the first case when I joined here in the month of September. I think mostly patient might be on his way coming here. He is a 35 years old gentleman. He is a local sarpanch, and he was hit by a lorry, and it was run through. And you can see majority of the physiotherapists and all, there's an open fracture, isn't it? Open fracture. You can see that that's called the laceration of the skin is completely open. Bones are dangling inside. Patient has come almost at the 9 or 10 o'clock. What do you want to do? What is the approach? Just whatever you want, you tell me. What do you think? What do you want to do this case? So we follow the principles that is called ATLS principle. Keep this aside. When you see injury like that, you need to expect something else might be happening inside. So we need to deal with the life-threatening injuries first, like airway, breathing, circulation, these things. You can tie a tourniquet on the top and you can leave the leg. It is not going to happen within 2 hours or 3 hours. But if he has a pneumothorax, hemopneumothorax, ribs are gone, something might be obstructing his airway. These are cervical spine problem. These immobilizations are very important. Why I am telling that, if tomorrow you might be going on something accident happen, you need to know what to do first. First is airway maintenance. All these things, immediately calling people. Cervical spine, one should hold and keep like that. If you don't have anything, stabilize it. These are very, very important. Why I am saying, not only outside, your own people may have suddenly some accident, so you need to deal with that. So this is what I got at night. So ATLS principles, stabilize the patient and the limb, get the investigations done, multidisciplinary approach. When it is like that, you need to involve vascular surgeon, plastic surgeon, and critical care people, everything you need to talk. And counseling the patient attenders, what's going to happen. If artery is severed, his limb is in danger. Nerve is severed, his limb in danger. What is the long-term outcome? All those things you should discuss with the patient and attenders. Stabilize the limb, pray to the mother nature to help the healing the fracture. That is the first thing, because biology always not in our hands. So first I asked a 3D CT scan with angiogram. Why? Because that fracture can cut the popliteal artery. We don't know, because pulsations are not possible, huge swelling in the limb. You can see that how it looks like. Simply, if you can tell in a layman thing, take a mirror and just put it on the floor. What happens when the mirror, if you put on the floor, pieces. See that there is nothing, everything is gone. So why I am telling you important, see this piece, that sharp piece can cut that sharp piece can cut the popliteal artery. You never know. See that, he is so lucky that piece never severed his popliteal artery. So what is next, what to do? Normally people what to do, take to the theater, wash it, put the external fixator, keep him in the, call the plastic surgeon, cover, take out external fixator, and again put the plate and everything will get infected. Why I am saying infected? Because you saw the injury, roadside injury, isn't it? Roadside, what happened? That the mud and everything might have gone, all sort of nonsense will happen. If you put a plate, you are encouraging bacteria to hug the plate. So then it is a problematic thing. So what you should do? That's why young orthopedic surgeons who are interested, even physiotherapists, again interested, you need to know Ilizaro technique. Ilizaro technique is not for every fracture, such type of fractures. Open fractures, bone gaps, non-unions you can use. So again, physiotherapists are again specialists in Ilizaro also are there. You need to know, they involve in the theater, they will see, you need to know pin track infection, you need to know how to maintain the frame, you need to know how much weight needs to put, all those things, okay? The important thing is muscle bulk improvement and everything, physiotherapy. So It's okay, we have taken that, there is no injury, okay, saved, popliteal artery is okay, and everything is fine, no other injuries, pelvis, everything is fine, I did all the things. Then what next? So, luckily that night I think Krishna and me are available. Our registrar, now he is associate consultant, and we both are there, nobody is there. Nobody, we both are there, that's all. You need to, Elizabeth here, our guys are not familiar, so it started at 12 o'clock, finished at 6 o'clock. My aim is to stabilize and put. See, I'll tell you something. Here, the fragments are like that. You don't devascularize the fragments because they are all attaching to the muscle. Because last week, I think I did a webinar. We put circulage wires. I did a forum. No, I told you they don't put, because they don't know, because arthroplasty surgeon knows what is the circulage wire importance. So what my plan was, I don't want to take out any bone, let the bones in place, make a tube and let it heal. See what happens. So you can see that, if possible I will play that. You can see. Sound rather than other than, okay. So you can see that, see how much it's opened completely. Knee is completely open, pedal. Ikkada sound bit. Ikkada sound bit. Vastadi. Ikkada betta idu undi ikkada. So another challenge what we had is 135 kilos weight, I'm sorry. So there is no ring to put, only veterinary hospital we have to go for the ring. So what we did, just we stabilized it. And the beauty of Ilizero is you can play like a, what you call that, cubes we play. That you can play afterwards, you can change the ring, you can change the wire, anything you can do. So see that, first we put the femoral, see this also. So we put the femoral ring. This is very important. So you need to spend time, clean thoroughly. There is a word called merciless debridement. You need to take out everything, whichever you see, black, stones, everything, thorough wash out, clean. Spend time, it will take time. It is not easy, these things. When you are dealing with these things, you have immense stamina and passion to do these things. Wash out thoroughly. Then, so I want to, first what I did is, I started reconstructing because there is intercondylar split. The femur has split into two pieces. You can't do anything with that. So first pass the wires to wires and just stabilize the intercondylar region, get a nice shape of the femur, and these fragments just I knitted together with circulage. Again, circulage where you don't put too tight, it will die. Just hold it in place. You can see that now knee joint is well maintained, and you can see the posterior slope. This is where the things come. So you need, when you are applying a Ilizero, you need to see that the joint is not subluxing either anteriorly, posteriorly. That you can check in the lateral view, beautifully aligned, and get the space nicely done. Then these fragments again, what you see in that all mirror pieces, bring it together, let it heal. It will function well. You can see now that I couldn't put anything up because his thigh is so huge. So what I did, drop wire. Just put a tentatively drop wire, make sure they are not moving. I closed it, I know that it is not going to survive, but I want that one temporarily, my bones needs to be clever. That is called moral lower lesion. Moral lower lesion normally you don't see quite often. You will see only when the body is dragged on the road because it is a shear injury between the fascia and the subcutaneous tissue. The minute they separate, the fluid accumulate, all the fat necrosis happen. That is not going to survive. I know it's not going to survive, but I want to stabilize the limb. Fantastic anesthesia department we got, and they helped us. 6 o'clock, we finished the case. Then next what? You can see that he came. I told you it is not going to survive. Don't worry. No worries at all. No infection will come if you know Ilizero. So, remove, debride completely. I think this one, Charan is there with me, I think. We both did, isn't it? Take out complete, merciless debridement. Why I am telling that, you need to counsel patient the process what he is going through with this injury. next time this thing can happen, next time that, you need to counsel them very intensively. So we removed it nicely. Next slide I'll go. Then what? Beautiful. Complete removal. Then what? Okay, next. This is VAC. VAC application. Spoke with the plastic surgeon. He told apply the VAC, let the beautiful granulation tissue come. Later I will do the skin grafting. Okay, done. Beautiful. It looks like a pomegranate now. It is ready for skin grafting. See, our plastic surgeon did the skin grafting. It is covered now. So see that. You can see there is a hole. Can you see that? That is called Morel-Lowell lesion. It will take time to heal. Next, what we did? I extended the rings. I brought the huge rings ordered. They came from Pune, and we put 2 rings and extended till the proximal femur. Now he is damn stable. Damn stable. Can you see that? With those 3, another 2 we added. So I want him to wait bare next. Oh, sorry. This is how it looks when he came to me. Don't worry about these fragments. They should heal. Okay? Everything is set. No bony infection. God's grace. Everything is going well. See what is he doing? See, skin grafting is healed. Beautifully healed without any infection. See, again, psychological support. Brother is very good. See how he is helping him to come down. So, when you apply Elizero, psychological support, Ajay has got his wife and mother who are supporting very well. Lingarao has got his wife. Both got fractures and admitted in our hospital. They are very great gratitude towards you. And these our international patients, they are also enjoying with Elizero. When I was doing my post-MS in Chennai health center, one fellow was putting Elizero and people are coming with alcohol and shouting. That time I thought in my life I should not do this one. That fellow daily used to have and shout, what is this pain? Then I stopped. After going Russia, after going Bangladesh with Professor Bari, then I decided I have to do it. And I don't regret doing it because none of my patients are drinking and crying. Then he started walking on his own, putting weight. You need to understand there is no limb length discrepancy. We maintained leg also fine. He's walking. And coming next, these are the present x-rays. Don't worry about this bone. Beautifully healed everything. Joint is maintained. Excellent healing. See what he's doing now. He came here with us. See how is he walking now. He doesn't have any pain, no brace, nothing, no limb length discrepancy. I'm waiting for that Jangaya to come and give his verdict. He's doing phenomenally well. He's going out. He's standing for election soon. But he is not reducing his weight, ironically. That is the only thing which is happening. Very, very happy people. And this is what an Elizero can do. Why I am telling, there is no infection. You have never seen any infection. Beautifully healed. No need of second surgery. You can just do whatever you like with that apparatus if you know how to do. That is the beauty of it. But you need to spend time though. So this is another one. This is a blast injury. This is a very poor fellow from Bihar. He was working in a company. He had a massive blast. He was admitted in another corporate hospital. 3 days they were there. They are about to do above elbow amputation. He came to us. He has a jaw fracture also. You can see suit and everything. Radius is exposed. Ulna is pieces. Everything is out. What to do? Shall we go and remove the hand? Shall we do above knee amputation? That is what he was posted for. Above knee amputation. So what we did here, I'll show you. That's all. Immediately they came night. I told, yes, we are doing. Immediately we took up. See that. You can see very clearly. See the pieces of bones, how they are hanging. Radius is out. Ligaments are gone. So how to save this one? It's very. I think Arun came. I think welding. You came to that. See that. Again, get the 3D CT scan. See that. It is right by Montisia variant, isn't it? Trauma. So again, brachial artery intact. Lucky guy. arteries never severed. So we can go ahead with the operation. And after the angiogram, oh sorry, this is how it looks. You can see that radius exposed, everything, suit everything. Again, the word comes merciless debridement you have to do. The sound rather పెడితే So see that what we did next again. Washing nicely. So once we done that, what is next? Viability of the muscles you have to check. How you check? Take a diathermy and just put over the muscle. If they contract, don't touch. If they don't contract, take out that muscle. You should not leave that muscle. You need to check first. Clean the hand, thoroughly debrided. Everything is working out for us. God's grace. So we are ready to reduce the joint and stabilize now. Happy? Then what we did? See, we reduced it. Once we reduced, the radius is looking towards capitulum, it is in the group, but only thing is, it is a comminuted fracture, not only pieces, down also there is a fracture, I'll show you, comminuted fracture of ulna. So what I did, I put a wire first and just put 2 circulage wires to maintain those fragments tentatively. I know I need to transport the bone, and you can see there is a fracture here also. So it is a comminuted fracture of ulna. Applied the frame, put it in place, the wrist also nicely done, and this is the frame I did. And you can see here, oh sorry, you can see here the frame. So there are 2 rings here and joined here, stabilized the one. And I left this place for the vac dressing. There and then we put the vac dressing. So I didn't put any rod here, just vac dressing. You can see that. So we check the pulse when we are passing wires here. So people think that elasoma means just passing wires wherever you want. If you don't train, wire can go into the artery and nerve also. So next what? So the team who worked with me almost, who is there with me? I think it took that this fellow is a specialist in elasoma with me, worked with me 5 years. I brought him with me. He does good job in the theater. So we did the team. Now see now what happened after the vac removal? Beautiful granulation tissue. Okay, next what? Next the problem has come, vitamin M. His company paid till then. Then what happened? We don't pay, you pay yourself. So vitamin M problem. Vitamin D means I can give. Vitamin C I can give. Vitamin M from where I can give? It's impossible. So then what happened? He went to ESI hospital, somebody helped him. So they did the skin grafting. Lucky chap, we did good work, no infection, beautifully healed. Then what happened? Really our hospital also very generous. So I requested our billing department, 10,000 he can give. In the pre-op, just we'll remove that ring and stabilize his elbow. They gave, we removed the ring and we manipulated there. That's what happened. Generously they agreed. Again, we manipulated in the theater. And now, see this fellow. He is going to work. He is earning his money. Hey, come front. Sir, come here, come here. So this fellow, can you imagine now? His mandible has been fixed in our hospital, elbow also fixed, and he's able to do that. If you remove, amputate, what is the use? These are the things you should do. His life is changed now. He is able to work. He has a family. You don't just take out the limb and send him like a parcel. Good. So, this is the one. So, next coming to hip, revision hip replacement. See, oh, not revision hip replacement, sorry. This is, where is our international department, Dilip? Is he here? He gets us cases which no one in the world, nobody can dare to touch. And he keeps with us, operate. Keeps with operate. All other, he gets also, you can ask Arun also. So see this. This particular fracture, she is from Cameroon. Operated 4 times, a very unlucky woman. 45 people are going in a wedding in a car, got accident, she is the only one survived, all other are died unfortunately. So it was operated 4 times, you can see the screws, bolts, what not. How she came with us, I'll show you. See this, in the theater. Oh, pick on, see, she was bed bound, not able to walk, 1.5 years suffering. So they told, come here, and they brought here. What is next? What to do? How to deal with this? Can you put a plate in infection? No. Can you put a rod in infection? No. Only one thing can save us. What is that? End of this talk, everybody should tell Elizaro. See that. What we do? We open it thoroughly, excise the sinus. Sound is the bound. ఇదిగో ఇక్కడే ఇదిగో వద్దు చెడగొట్టము మళ్ళీ పోతుంది. So open it, thoroughly debride, tissue all excise the bones ends which are vascularized bones, and then thorough wash out. Then I'll go fast, I think other speakers also give a talk. So then we measure how much bone is going to lose. How much? 4 centimeters. So my plan is how to cover that 4 centimeters. From where I should get? I can't get any bone bank. Can I? Nobody will give. So it is there in the Liverpool bone bank, big one, but here we don't have any bone bank. So I have to get the bone from above to down. How? See now. So what I do, that is stimulant. We put the stimulant into the bones so that antibiotic cement we put inside the cavity, make sure that infection won't persist again. After that, Elizaro, put the Elizaro frame, do osteotomy. Distally. Already I have cut the bone there. That bone gradually I will bring it down. So 2 things it is doing. It is gaining the length, limb length, and also healing. And why Elizaro is, when you do the vascularization, the antibiotics what you are giving will go to the bone. So healing will occur. These are all, so many things are there with applying that. So we pass 2 wires from here because the bone has to track down. Then those beads are stimulant beads we'll put inside. And see this patient next day, she was 140 kgs weight when she came here. I'll show you what happened at the end, you will be surprised. I call her Mama Cameroon. See the next, one day she was depressed. We don't even do the surgeries, we also encourage the patient. I'll show you what I did that. See here. So we encourage the patient. When they are dull, we should also encourage them, not just operating and throwing them in the bed. So next what? This is the one. Nicely bone is coming down. You can see that callus is forming there and it is going down. And this is where I did osteotomy. It goes down and unite there. You can't do anything except that. We need to give. See, she came just 2 weeks back. Reduced weight. Elizaro also helps you to reduce weight. You don't need bariatric surgery. Do you think that? And see how happily she is walking now. Have a look. Fantastic. She got the limb length, happily putting weight and walking. I think I showed you also. She's happy. So whoever are going to have the Elizaro, they won't suffer. They will be very happy. This is the witness. So that's how now. We'll go quickly. It's good. So this is another one, very interesting one. This is called hip resurfacing. We call it as a Birmingham hip resurfacing. This lady came from Orissa. Someone referred to us to this hospital to come and meet me. The important thing is metal on metal. When it causes rubbing, it releases ions, which increases and cause pseudo tumor. And unfortunately, she landed up into both the kidneys, chronic kidney disease. And our Dhananjay is planning to get replacement soon. They came here for revision surgery. And already Johnson already reimbursed the amount also. Yes, sir, sorry. See what happened. We removed it. We removed the thing. And we revised this one with bone graft and screws. And patient was very happy, believe me, very, very happy. That is the revision because I lost the videos, so I couldn't play them. So this one is another gift given by our international department. What do you want to do? 5 surgeries has been done on this. He's a soldier. He came from your friend, Matthew. Do you remember? He came from Cameroon. And I should say thank you for believing in me and asking me to do this case. Thanks for having hope on me, sir. So he came with, fortunately, he doesn't have any infection. That is the only lucky thing. So what to do next? See, how many surgeries has been done? DHS has been done, long DHS. It is looking towards north. And that's failed. Actually, I think this surgery, hemiarthroplasty, or at least bipolar should have been done. The wrong diagnosis. And one nail has been put, and again X-fix has been put. Like that, they tormented that fellow. He landed up here. What to do next? You can't survive that bone because it is gone. So we went and did a proximal femoral replacement. So that is the proximal femoral replacement. The challenging here is, now I am presenting it is very easy. It is very difficult to find out the canal, version, cup is not there. I think Charan is there with me. Charan knows how difficult this case. Cup, we don't know where is the cup. We created everything. We did everything. This is cup version, proper cup version, and putting the metal thing. And cup looking very good version and inclination. Next what? See, band of brothers I call, both of them. Both soldiers, happily they are walking. I can't put all the cases whichever I have done. Matthew is there, he is there. He never walked about 2 years. He was just in the bed, unable to do. So anybody comes to Continental, they will get up and walk. Nobody will sit and sleep. See how happily they are doing both. Hey Matthew, do you remember? Yeah. Good. So you can see the prosthesis beautifully aligned and absolutely fine. Where is the colonel? Your colonel, where is he? He was telling the patient was very happy, and he is very happy. And thank you very much, sir. So, sorry, this is another one. Open book fracture, pelvic fracture. These are the injuries which are going to kill us instantaneously. So there is no question of room here. You just sit. You have to go and act immediately. I'll tell you, I think some major case I did. I went around 8 o'clock, 9 o'clock. Just I stopped my car in front of my house. Suddenly call came, sir, you have to come. Raghu sir is calling. There is a pelvic fracture. Tractor went on that. I should say that thanks to my wife, she came. She sat in the fourth floor. I think, Krishna, you are there, no? 4th floor. She was there till morning 5 o'clock. She got us some KFC food and everything for us. And she supported us. I should say thanks for that. You can see open book fracture. Open book means book is like that. It opened like that. So how it opened? See, SI joint is open, is an unstable fracture here, inferior superior pubic rami fracture, and pubic diastasis, symphysis diastasis, and there is you see, this is the dangerous one. You can see that comminuted fracture of the sacral ala going to S1, S2, S3. Still patient is having slight radiating pain because we can't do anything with that. If you open, think that you have a chocolate inside a cover. Bang it with a hammer. still the cover is intact, pieces are fine. The minute you remove the cover, pieces fell apart. You should not do. That's what when to do, when not to do is very important. Then you can see that posterior also is open. Then what to do? See next. So we were sitting there. We are ready at 11 o'clock. Krishna is there. My registrar is there. Our DNB guy. So we did angiogram because notorious bleeding comes from the venous plexus. You need to know it. Because we do this so that interventional radiologist will come and embolize the artery or vein so that we are safe. Otherwise they will bleed to death. So everything looks fine. So we are ready and we did the X-fix and stabilized the patient. Beautifully, everything is stabilized and BP back and blood pressure, everything is stabilized. So we waited. And this fellow also had a moral lower lesion. So very funny thing happened, sir. I need to share with you. Stabilized, he is in the ICU. His blood pressure is falling. Then we were thinking what's happened. Then went and examined personally secondary survey. I found out bleeding is tracking here and forming 500 ml of blood inside. So aspirated, applied the bandage because that is called moral lower lesion. So survived and transfused, is fine. You can see that this is a stopper approach. Stopper approach means we'll go here. We'll open here. Stopper approach. And I took help of our urologist Harsha because the CT scan shows that there is a blunt injury to the bladder. When I opened, I don't want to get any surprises, so I asked him to come and see the bladder, document bladder is fine. Beautifully opened stopper approach. And you can see that we fixed it. Symphysis reduced and fixed with the plates. You can't play any games here. Anything you do, you hit the bladder, you hit the obturator nerve, you hit everything. So you should be very, very careful, time taking, and it will take time to do it. It's not that easy peasy one. And this one here again, yeah, we fixed it nicely, reduced it nicely, and it doesn't work here. Once it is finished, close it, and again SI joint screw I have to put to stabilize the SI joint. So next what? So we reduced it and we passed the screw and stabilized it. This is also notorious. You have to go exactly in trajectory, otherwise you will hit the L5 or you hit the artery. So next what? Is fixed nicely and is absolutely fine. Don't worry, the drill bit is broke when we are doing the X-fix. And our Srinivas is started putting impartial weight bearing and walking. He came last week and is doing absolutely fine, except pain radiating. I already told because of that sacral comminuted fracture. So this is what next, reverse shoulder arthroplasty. This is very, this patient came from Bangalore to get operated. You can see right side completely gone, very challenging. Left side also, he wants left to be replaced, and within 3 months we are doing right. Me and I took help of our Chakradhar, my colleague, and we both did the case. And you can see that 3D CT scan, we had to take version and everything. And we did the case, beautifully came. Patient came and also they have given their feedback and doing amazing, and he's coming 3 weeks for our shoulder. Next, coming to revision knee replacement, unfortunately I don't have x-rays. This lady is almost 130 kgs, and after revision I made her to get a bariatric surgery done in our hospital. She had bariatric surgery also. She is in Singapore now doing fantastic. You can see PET scan is taking so much of dye here. So the main thing is here in the tibia, loosening. It is not infection, aseptic loosening. So how we do in the theater, that also I will show you. Secret, sound is not coming. We have a big music every time when we are doing revision. Unfortunately, it's not playing here, otherwise it would have been very fun. So, excellent surgery done, and patient is, see, that's what I'm showing, the part which is not properly, the cement hasn't integrated there. So we took it out. Then we replaced, here also there are huge cysts. So we opened the cysts, everything, and put the bone graft, and also did some cement inside. That's why it is sunk one side. So then what we did the long stem and beautiful replacement. She is absolutely fine. Coming to this one, this is, thanks madam. Madam, thanks for referring this case. Thank you very much. This, why I put this slide, very, very important. 8 years old gentleman, neglected, not undergoing knee replacement for, I don't know the reason, and kids are out, went to a normal gentleman and they started injecting steroids inside. What happened next? He is an immunocompromised patient. He is a chronic diabetic. If any physiotherapist want to give injections, please come and learn from us. See what happened? This is how he presented. He went to Apollo, they put vac. Don't do vac dressings at home. It is not sterile. The person who is doing doesn't know what he is doing. He is doing daily vac dressing and he is telling, don't come to room, I will do and go. Madam told, can you go? Why madam referred to me? Went to Apollo, went to Yashoda, everywhere they told he won't survive, we won't operate. I counseled him, properly counseled the patient. I told them, I'll take challenge, I'll do it. But he may die on the table, shifting the table, or inside the, what you call that, inpatient. They agreed, I will do 100%. That's what you need to counsel them, talk to them truthfully from your heart. So they accepted me and we did the above knee amputation. That day I felt very bad because 80 years old above knee amputation means it is a punishment because we took it out everything and complete infection has been eradicated. Did the above knee amputation and 1 minute. Where is it? So the limb also we sent there, removed complete limb, and he is happy. And this one is again our, I think today international department is nowhere senior. This one is a very interesting case. Look here. The surgeon who did this missed the diagnosis. It is a DDH, developmental dysplasia of the hip. You will have a hip, instead of like that, the establer cup will be like that. That fellow opened and did, where he put his cup? Where is it? In the ilium. He has put in the ilium. Cup should be here. Cup should see there. This one done in nice, whoever did the surgeon did good job. You draw a line, it should be here, but he put it here. She was not able to walk, and again periprosthetic fracture, 4 operations, plates, rods, whatnot, everything they put, she came, they want revision. She had a TB hip, same side. So we did always do multidisciplinary team approach. We have a very good infectious disease specialist, discussed with him. I had a meeting with microbiologist, how to proceed, what antibiotics to be given, what are the samples to send, everything beautifully done, recorded. Then what we did, you can see, CT scan, see the fun here. Where are the screws? Screws are in the air, they are not in the bone. Where is the cup? Cup in the air. It is not in anywhere. So patient is in air whenever she is walking. See that? So these are the things happen. If you don't know how to do, and if you don't recognize preoperatively what is the real problem, these are the things. She is only 42. Her life is condemned completely. Then what we did? See the insertion, it's like a snake going from South Pole to North Pole. See that massive incision. So what? So opened it completely. And again, my word is merciless debridement. Open, see the cup is just dangling and bangling inside. There is no hold at all. So removed the plates and removed the stem, everything, osteotomy done, completely removed, thorough debridement. And see how we remove this thing if you don't come. Have a look. So after hard work, so we made a mold. This is called mold, antibiotic mold. We remove it and put antibiotic mold there. After 6 weeks, we have a PICC line. We have antibiotics after the culture sensitivity. Till then it will be there. After 6 weeks, I am going to do revision. She has a 10 centimeters of shortening, and we have to cover it at least reasonable height where she can walk. And again, put it back, nicely reduced. And this is what you see that. Can you see that? Yeah, everything is knitted back inside. And when you are doing revision after 4 times, you don't know where is the sciatic nerve. So what you should do? Go and check the patient foot, whether she is able to lift or not, because you have to document. See that? Luckily she is able to do that. I said, Om Namah Shivaya, God saved me. Because we don't know, no one is sure. What, Chakri, do you agree with me? No one is sure. But luckily, went well. So So this is one. Patient is very happy. I made her to sit next day. You don't need to, see the future is stabilize and mobilize, no question of immobilize. So what is next? I asked her to walk. She is walking. This is what you should give to the patient, isn't it? Go into the shoes of patient. If anybody puts you in the bed for 3-4 days, what happens? You will become a maniac. Happily she is walking. I think yesterday she is discharged, I think. Shabina, she is discharged yesterday? Oh, okay. After 6 weeks, we are going to revise hip. So this is the last case I am going to do. If I go on telling, it will take evening, so I am stopping here. This is the most challenging case of all. Why? Why challenging? I posted to my boss, he told, fingers crossed, hope for the best. I don't have that dare to do. He told me same words I have sent him. Look here, what happened? This is also soldier, had a mine blast, completely opened up. What is this? What is this condition called? Chronic osteomyelitis. Complete femur is gone. There is nothing you can do. Nothing you can do. Just one rod is hanging. See that everything is eaten. Eaten completely. There is nothing. So what are your plans? Multidisciplinary team approach. Get the consent from that. Explain to the patient what is going to happen. 1.5 years I have given that time because I have to get the bone from here to there. I will show you how much length I have to get the bone. It's not easy. So, don't know. See this. Completely opened up, and you have to merciless excision of all the scar tissue, merciless removing of the dead tissue, dead bone and everything. It took 7 hours for me. 7 hours not for the application of Ilizado. 7 hours main thing is debridement. You have to take the slime out. You have to take the sequestrum out. You have to do the de-roofing. You have to mercilessly cut the bone and see where the viable bone is there. That will take at least 3 to 4 hours. If you don't spend time, you don't get the result I am telling you. Next. Yes. And again, we drill the ends. Make sure it's bleeding. That's why I tell to my team, have a brunch and come. Eat nicely, everything and come. And don't scold me inside. I used to tell everybody while starting the case. So once that is finished, so again stimulant bone, we put into the medullary cavity. You don't know, Chakri, how many cloacas are there. Continuous bone, slime, that much slime. I'll show you, the slide is there. So put nice stimulant everywhere. And you can see that, see that, the slime. This is the bacterial slime inside. Then what I did, look here. That is the length we should achieve. We passed the 10 nails because when you are bringing the bone up, there is something should guide you. That wire will guide exactly top. Then you can see that the wires went inside. I packed all the stimulant and wires are here going to the trochanter, and God should help me, that's all. Next. And this is the frame we did, so that here majority of them are, nobody puts wires in the proximal femur because proximal extremity of the artery as well as sciatic nerve behind and also femoral artery. If you know the anatomy, you can go ahead well. So the wires has been put. That is the length I should get. The rod, what is the rod left? That length of the femur I should able to get. Stabilized nicely. Then what? Finished. Thank you very much. That is the end of the show. I can show you still beautiful cases. There are a lot of cases. Unfortunately, Ajay case I didn't put all other cases. See, he's clapping, the femoral man. The back soldier is clapping. So that is what it is not that I am great. It is not that I will. There are a lot of people who can do fantastic surgeries. This is what our passion. This is what we are doing in this hospital. Our team is consists of fantastic surgeons. We are all very close knitted. We discuss and we do any complex case. I am not asking you to send primary hip or primary knee. I have seen the cases now. Send such type of cases, we will do it. Okay? Thank you very much. Thanks a lot. Any questions? Sorry. Any questions you want to ask? Any questions? Srinivas. External plating, see, what type of injury is it? Open wound. When the bomb blast, open wound, such type of ruckus.
Instead of internal, external plating, is it possible?
That's what I am telling. If you put the plate, if it is infected, what is next? No. If it is there is a protocol, Gustlow type 1 and 2, not like these injuries. You can go and plate it. You can put a rod. But these type of injuries, if you put, this is my way of dealing, because I don't want second surgeries. I don't want to sit in front of them. Sorry, I can't do like that. This is how I execute. This is how I give result. I am very happy doing things. I don't want to burn my fingers, isn't it? I know what is going to happen, isn't it? That's why. Maybe other person, if Chakri can do, I can do the plating, but I can't, because I know what happens. Arun can say rod, but if they are happy, their results are good, they can do. I am not saying this is right, that is wrong. I know what will happen, where I will land, so that's why I won't do it. We'll do nailing, we'll do plating, everything. If it is, I told you the beginning, if it is necessary only, Ilzero. Not for everything, Ilzero. Nobody, Ajay is there, that is Chakradhar case. He called me, open fractures, can you do? I am going to out of the country, can you help me? I did Ilzero for him. Why? Because it is necessary. Open fracture, everything is open. Arun also sent me a case, one case, Prakash. Complete pieces. Beautifully they are walking. Results are there, no, when we do that. They never come with infection or anything. Did you see any pin track infection? Did you see anybody is crying and shouting? That's all finished. Thank you very much.
So one more question for everyone. How much time it will take for Elizaro for rehabilitation, to ring removal?
See, now his is only 6 months. Now he is coming for dynamization after. Dynamization means what? We will loosen the, to make sure everything is fine. Then we'll remove, put PTP and send him home. That's not finished. Now, a femur, what you have seen, it will take 1.5 years, because I need to know how bone is growing up, how it is growing, whether there is any callus fracture, anything else I need to do. But that's why 1.5 years. This one again, I am going to dynamize all these things. It's not a problem. Another thing, even diabetic ankles. I think you said that case. Diabetic ankle is yours, isn't it? Diabetic ankles don't fix it. If a chronic fellow, old fellow, diabetes, put Elizero. Beautiful result. I have done already. He is walking and dancing. Okay? Thank you very much.
Thank you, sir. What a powerful presentation. Now everybody must have understood what Elizaro is and how complex the orthopedic traumas are. As Guru sir and Gautam sir has already explained, it's not just putting pins, needles, pins, rods and plates. It's how to do it, what to do it, when to do it, and get the best results out of it. Thank you, sir. Thank you so much. Our next presenter is Dr. Chakradhar Reddy, sir. He'll be presenting some new cases.
So, I'll look at my room, please. Okay. This is pointer, first of all. Okay. This is slide changer. Next, previous. This is the changer, is it? Yeah. Okay. Good morning or good afternoon, ladies and gentlemen, sir, Guru sir, Raghu sir, and everyone who are in the conference room. I am Dr. Chakradhar Reddy, one of the senior colleague of our orthopedic surgeons, and maybe close friend of Gautam as well. Well, I mainly do not Elizaros. I fix it, and then I do most of my practice is sports medicine and joint replacements and upper limb replacements. I'm an upper limb surgeon rather. Okay. See, I'm just showing few of my cases, not to show every case because there's no point in showing every case. And see, I just want to show this one, very important one. This is a 6-year-old lady, girl rather. She's not 6, she looks 4 only. Her elbow is like only 6 inches. Okay, her forearm. And then she fell down from a trampoline, or I think she was dancing and she fell down the night before. She went to a different hospital. They took an X-ray. I'm sorry, I don't have any of those things, but I got the information. She went to 2 different hospitals, and both of them they took the X-rays, and nothing was. Everybody found it's not normal, and then they came to Continental in the middle of the night. One of our colleagues has seen and advised some X-rays. They also, when they tried to find out something, yes, we at the middle of the night, we thought of, okay, be safe, we'll do an MRI, and they called me overnight, and then I spoke to them, and then I asked for a CT scan. Anyway, in the X-ray itself. Okay, anyway, before that, this is my track record. So as in so many hips and knees and shoulder replacements, reverse shoulders and shoulder resurfacings.
Sir, you can
And okay, anyway, I don't want to boast myself. This is my work in the last 22 years. And, oh, the slides is slightly messed anyway. Sorry, anyway, I'll tell about the little girl. The little girl was like, as I said, we took a CT scan. The CT scan shows the epiphysis. Epiphysis means the growth end of the plate of the distal bone of the bone will be forming yet. It's still forming. In the radius and ulna, the 2 bones in the forearm, the radius head is not at all fully formed. So it's been missed. But the baby is crying. She's not able to do flexion, extension, bending, everything. And she's crying, nobody knows why. And then we found out after the CT scan, the radial head was like in the middle of the forearm. It's completely off, slipped and displaced, off-ended, and no connection between the bone, and it is in the middle of the forearm, and the baby is like, the hand is like this big. Okay, I don't have the pictures, I'm very sorry. And then what I did is, I took her to theater the next day itself, and then I have only one chance, because there are so many important nerves which can give hand drop, because the radial wrist drop, because of the radial nerve, okay? The radial nerve is very important for anyone, especially for the kids, on the right hand. That's the right hand. So I took meticulous dissection, and then I made sure that radial nerve is well protected, because that's not very far away. That's only a few millimeters away. And then I got only one chance. I have to find out where exactly the radial head is. It's not easy to find out because CM won't be showing the radial head. I had to palpate, and then I had to make sure that the radial head is somewhere, and then dissect it, remove it, and then I had to put it in the place. I don't know whether I have the slide. Sorry. Carry on. Sorry, I think I missed. Yes, yeah, that's the one. Can you see this? Here's the pointer. This is the pointer, right? See, it's here. And everybody thought it's just normal X-ray. Can you see this? It's somewhere there. Can't even see, appreciate. It's very difficult to read an X-ray, especially in a kid. And then I fixed it with one single K-wire. I got only one attempt, and not to damage the nerve, and I had to fix it. And the baby is the young child, very, very nice girl, happy parents. They're like, they don't know what to do. And then I did it. That's all. Okay, only one attempt. I don't have any other attempts, sir. Otherwise, if I pierce multiple times, it will break, and then I can't fix it. Second thing is, if I pierce multiple times, there won't be any growth. So, I mean, I was shivering, I'm telling you. This is my first case of this type of thing on my own, and then, but it has gone very well. They came few weeks ago. She's doing very well, and she already sent a knee replacement patient to me, her parents, and then they're happy. They are from Bhimavaram. Okay. So, I mean, sorry for the, I mean, the slides are ups and down. Okay. And the other one, sorry, I'll present as it is. Okay. This patient, yes. This, yeah, I'll present randomly. I'm sorry, I didn't really organize them very well. This is a commissioner of police who became a commissioner after my surgery. He was an IPS trainee at the end of his career, end of his trainee, 5 days or 6 days before of the training. Okay, he was horse riding at the speed of 80 miles per hour. 80 miles per hour. Yeah, no, he fell down. Okay. Yeah, next time. Yeah, I'll give it to you. Okay, right. And this guy, he's a doctor. Basically, he's a doctor. He's a doctor from Chennai. He elected not to go for like all of us did. And then he chose wisely, probably, to become an IPS guy. So he passed it, and then he became an IPS guy. He finished his training. Just 1 week before, he fell down from his horse at the speed of 80 miles per hour. And then I think he went to a different casualty first, and then they told me I mean, that's the X-ray. I mean, I don't have his previous X-ray. Sorry, my preparation is very bad. Okay, basically he broke both the bones. I mean, we got 2 bones here, right? Both the bones, and both the bones are like very badly injured, and radius and the radial side has been broken into 4 pieces, and the ulna was broken into 2 pieces. Charan was there on that day. Luckily, that was a Sunday. I still remember that case. Okay, we took a lot of time to do it, and before examining, and the patient is a doctor, right? He knows, and he was telling, he went to a different hospital, and then those guys neglected it. He was telling, my finger is numb, sir. It's a closure fracture. We normally won't expect any neurovascular injuries in a closure fractures. That's very, very, very rare. It's almost like 1 in 10,000. So and everybody thought he's moving his fingers, and we all thought that okay. They all thought that it's okay. We can do it the next day or the day after, because the next day is Sunday. Anyway, I wanted to finish off this case. I came in the morning. I have seen him first time in the operation theater pre-op area. I've seen him. He's a doctor. He's apprehensive, but very nice guy. Okay. He had I asked him to do those palmar tests for the ulnar nerve. He failed to do. Complete claw hand. I took a picture of it. I lost it. Okay. Complete, ulnar claw hand means his ulnar nerve is not working. And then I thought, okay, ulnar nerve is not working. I had to document it first. So documentation is very important. Otherwise, something can happen, and then he might go to court, and then they might blame me that I have damaged the ulnar nerve. So documentation is very important. So luckily, luckily I took him inside the theater. We fixed the radius. which took me a long time because it's a very, very, very bad radius. It's not, hasn't been healed, hasn't been seen here, but it's a very bad fracture. And then we started ulna. Ulna is the other bone. When I opened the ulna, to my surprise, the ulnar nerve was in between the bones. It's like arching inside. And then I was like surprised, and then I thought it was a neuropraxia. It might have been just stretched, and then it might be in its place only. But it's not the case. It was caught in the fracture site for the entire night. Okay, then I thought, okay, we had to take a picture of it. I lost them as well, and then all the pictures were documented. I got in a different phone, but I don't have the phone right now. And then everything was like documented, and then I proceeded for fixing the fracture, and then I explored the ulnar nerve, because if you don't explore, the ulnar nerve might have been cut somewhere else, and then I don't know. So I explored it. Ulnar nerve seems to be intact. Okay. Then I thought, okay, I'm happy, and then I fixed the radius, ulna, and then he is fine. Post-op, he never recovered his ulnar nerve. He took like 2 months, 3 months, he didn't recover. After 4 days, after 4 days or 5 days, I noticed his little finger is cold. Why it is cold? Please tell me, why only little finger is cold? Can anybody guess? We have, yeah, guess it. Yes, you're right. Along with the ulnar artery, ulnar nerve, ulnar artery has been thrombosed. No, the same area. Same area. Both. And then I did a angiogram and everything. Artery is intact, but there is a blockage. There is a block. Clot inside. I'm sorry, but I didn't even expect. That's my first time. I thought ulnar nerve is gone. Fingers are numb, and then I couldn't examine his ulnar artery pulsations at that time. And then after a few days, I recognized that is the ulnar artery as well injured, along with the ulnar nerve. That's the right hand. Right hand, isn't it? Right hand, yes. And then what to do? And then I spoke to our eminent, colleagues of our hospital regarding the artery, what to do. Well, they told me it's already 3 to 4 days. Ulnar, because usually our hand will function in such a way that we have a compensatory mechanism. Ulnar artery and radial artery, they form a crisscross or an arch in the palmar arch, 2 arches actually, one deep and one superficial arch. They create an arch, they cross supply to a little extent. But the problem is ulnar artery is the main branch than the radial artery. I went for the radial approach for the plate fixation. If I would have cut the radial artery in that case, that will be an amputation. Okay. Luckily, nothing has happened. Okay. Then that colleague told me that okay, after 4 days or 5 days, we can't re-embolize. We can't do any thrombolysis. It's a very tiny artery. It will over the time it will improve. Collaterals will form. It will improve. And then he went to Chennai, and then the Chennai is famous for it's a good center, right? He went to Stanley. Stanley doctors were reviewing him, and then till what? Sorry. Okay. How to go? Till 2 months, his hand is like this. Claw hand. No, yeah, probably not. His ulnar, it's an ulnar claw hand. His ulnar hypothenar remnants is still wasted. No sensation, still 2 months. and till 2 months from now. So 6 months has gone, and then is not improved. Is probably his bones might have been united, and then he's worried about the thing, and then he's not sure what to do. And those guys were planning for what? Tendon transfers. And he's going to join his new post. Okay, and then he spoke to me over phone. I always keep in touch with any patient which is probably risky. Okay. Yeah, inflation. Not influential. I have a habit of keeping all those numbers, and then I'll do them anyway. And then he spoke to me, sir, my ulnar nerve is still not recovering. It's still there like this. I asked him to come. He came here, and then we did the this EMG and nerve conduction studies. Nerve conduction studies are not working. I did an angiogram as well. Okay, and then angiogram. Luckily, his angiogram it recognized, and then the finger is warm. I thought, okay, half of the job is I'm happy. At least I missed that part. I was survived. But what to do with the nerve? And then I found out the EMG. In EMG, the potentials are positive. I told him, okay, you got still a chance. Usually we tend to do tendon transfers after a year or so, until the joints has been supple, or there is more than 12 to 18 months of time to lose all those neuromuscular junctions. Otherwise, there is no point in doing it. And then after 2 months, I don't know what miracle has done. He came yesterday, and then now I just want to play. See, he's not having any. He gave me a testimonial. See,
you are a doctor and an IPS officer, are you? Okay.
I'm Dr. Prasanna Kumar, basically undergoing my IPS training at National Police Academy, Hyderabad. So during one of our horse riding sessions, I had a fall with my outstretched arm.
Okay.
I had both bone fractures in my left forearm, ulnar and radius, and it was a comminuted fracture. And my ulnar nerve also, there was a lesion, I think, because complete motor and sensory loss. So I was operated on 26th morning, the next day of fall. And after the operation also, ulnar nerve deficit was there, complete motor and sensory deficit was there.
See,
after a period of almost 8 months, I think it has improved much.
Can do that.
And sensation, I think 40 to 50% recovery is already there. Motor, I think 70-80% has come.
Good.
Bulk all has come properly.
Bulk has come.
Adduction, abduction.
You got adduction, abduction.
And everything is.
You know that your ulnar nerve was stuck in between the fracture. And then you had an ulnar artery thrombosis as well. Even that recovered. That's why your finger is more warmer now. Okay, but you are such a lucky bugger.
Okay. My conclusion is cases can be so different. See, it's a closer fracture. He just fell down. He got both bones, radius and ulnar fracture. The speed. Yeah, nobody noticed it, and then the speed is sometimes bad luck. Usually they will neuroprax, they won't get caught. And one thing is okay, having ulnar artery also is like, I have never seen. Probably we can publish this. Wife and husband. I don't know. You should tell. Okay. Anyway, so the moral of the story is, I did my best, I tried my best, and he was lucky actually. And that's not a great case because it's not a technically very challenging case, but it's a very interesting case. And he's happy. Okay. Smiling, right? Everyone smiles. Okay. This I had done couple of days ago. Okay. Dr. Guru sir also knows about this patient. We had a long discussion about it, how to save this patient. And our international department, as you told me, told everyone as well, they are fantastic department we got here.
we got here. I have done so many knees and hips out of the international department. They are like president families from Cameroon and mayors from Cameroon and everything. They're all fine. I don't want to discuss those things because they're all simple knees and hips. But this patient is a soldier, normal soldier. He got a very good nice biceps and triceps on the other hand because he's a soldier. And the right hand, and the left hand, poor guy, he got a bullet injury exactly over the brachial plexus. The bullet went through the brachial plexus, Arun, okay, and then it damaged the entire brachial plexus, ripped the brachial plexus from the spinal canal. Preganglionic injury, we cannot do anything. I worked with brachial plexus unit in Glasgow for an year. As I know exactly what to do for these brachial plexus. I have done quite a few brachial plexus repairs as well. But in this case, after 7 months, I don't have his thing. I'm sure it has been recorded. His hand is like just not doing anything. It's like this only. That and painful, wasted, and he didn't take a bath, or probably it was like blackish, but it's surviving. No movement at all. For that, we call that as a complete brachial plexus injury. Okay. In those cases, what to do? I have decided by discussing with him psychologically, physically, emotionally, and with the parents, with their parents over phone, and with our boss, and with the international team, everyone recorded, and then I have to at least give him some support to carry something, okay? And then how can he carry something? His baby, a bag, to have a stable joint, because the joints are like this, and the hand is not working. Only bones are working. Bones are there. So I know this is a normal shoulder. I was feeling sorry to remove all those cartilage because I normally try to. That's what I had to do it. I took time to remove all the cartilage. Usually shoulder fusion is not because we don't fuse the glenohumeral joint. Only fusing the glenohumeral joint, the actual shoulder joint, is not the option. We don't fix it because the glenoid is only 5 centimeters. The humeral head is so big and they won't unite. We normally proximally migrate it and fix with the arch, the acromion and the clavicle and everything, so that it's like a entire dome of the thing, and you'll have a elevated shoulder, and then it will be united. That's my goal. That's the reason why I lifted the humerus up and fixed it with the acromial arch as well as the glenoid. That's one thing. And then we have to fix the shoulder or the shoulder fusion in a functional position, not like this, right? Okay, we have to fix it like this. So 20, 20, 20 or 30, 30, 30, there are so many debates about it. So 20 forward flexion, 20 abduction, and 20 internal rotation. I did that, and he's doing well, and he's half the job is gone, and the other half I'm trying to do the elbow fusion as well, maybe day after tomorrow or tomorrow. At least I'll have a stable limb for him to use, so that he'll be at least using his arm rather than going for a complete amputation. And he's happy. Yes. Yeah. Okay, this is another 6-year-old girl from Cameroon. Her complaint is like she says that, Dad, my elbow is not looking good. My elbow is like odd. Something is coming out from here. I can see the protrusion here. All my peers are like making fun of me. What to do? His dad is a very good IT guy in Cameroon, and then I spoke to them. They came here, and then it's a congenital radial head dislocation. Radial head is not in the under the coronoid. Can you see that? Can you see this? It's not only displaced, it's been displaced posteriorly, displaced laterally, and capitulum is not in line. And then if I don't reduce it, the alignment will be gone, and then the capitulum growth will be gone, radial head growth will be gone because you don't have the pressure. So what to do? Then I fixed it. So how to fix it? How to fix a dislocation which has been congenital and that too out for like 6 years? What to do? And then I went to the literature, I read everything, I spoke to my boss abroad, and then there are only literally 5 cases in the world so far which has been done like this. Okay, and probably this is the 6th one, I believe, if it survives. Okay, we have to harvest the palmaris longus. Palmaris longus is an excess tendon in our body, which is a tendon that we can use as a sling to bring the radial head back to the original position. And luckily, I have to construct the annular ligament, which is the ligament that is supposed to be intact, but for some reason it's not intact and it's been lost, or it has never been formed. So, and then I reconstructed that with the palmaris longus, and that too the approach is very dangerous. Everybody is apprehensive about the radial nerve, and because she is very tiny, growth plate, I shouldn't disturb the growth plate and everything. And then I reconstructed the annular ligament first, but I reconstructed that with the palmaris longus. Okay, palmaris longus is a thin tendon that won't have the strength to maintain the tension. Then what's the option remaining for me? Put a K-wire to stow it, or I thought, okay, K-wire is a bit too much, because I don't want to give a K-wire because he wants to go to Cameroon after 4 weeks. Time is also another important factor for me. And then Arthrex got a nice tightrope thing, and then I rounded it around the radial head, and then tightroped it and fixed it. See, it's been fixed. Yes, I stabilized it for 4 weeks. Yeah, there is bowing, but I thought, okay, let me give it a try so that I can do the slow and steady. They will remodel if it is there. And I got I spoke to him, and I always keep a track of my patients, as I told you. And then I spoke to his dad, 4 days ago or 5 days ago, and then he's doing very well. He's doing also pronation, and she's happy. And she's 2 months down the line. Anyway, next patient, what did I do? This is another basic one, is it? Okay. How to go back this one, right? That's the back one, right? No. Okay. I haven't included a slide. This segment, yes. This another. Okay, sorry. Time is running. I'll finish it fast. This is a guy who is very unfortunate. All the nerves are not working as usual. He's from Cameroon. All the radial, ulnar, median nerves are not working. He's in VAC. The hand is not working, and he got a bad he get a bad uh, see, that's how his X-ray is. It's like we can't do anything, but it's luckily there's no infection. Okay. Initially, I wanted to do in two-stage procedure. One stage is I want to make sure that all the nerves are intact, and then I released them. They are all luckily intact. All of them are like released, neurolysis, and he's much better after that. And then he came to me after some time, and then there was a non-union as we expect anyway. I put a plate, and the plate is holding it, and it's doing well. And I'm sure it will unite. And he's doing well. I spoke to him as well a few days ago, and he has sent another patient as well to me, and then he's doing well, and he's happy. Okay. And the last but not the least, sorry, I didn't record. Do it again. Back is it? This one.
Model of presentation. So
The elbow
basically,
elbow replacement. This is another one. It's an old procedure. He got a cubitus varus because of his supracondylar osteotomy when he was young, malunited. I did a French osteotomy on him, and then that also corrected beautifully. Yeah, these screws corrected the alignment, and then he got his carrying angle. Sorry, I didn't. I want to see that elbow replacement. Go back. Yes, she's around 55, a chronic rheumatoid arthritic elbow, no supination pronation, functionless because it's not in the functional position, left hand. She came to our hospital. She came like this. There's nothing there. There's no elbow. Ankylosed. And then painful. Synovitis. Okay. And then I did it. It's not that, difficult, but I did it. Pain-free. And now I got a video, I believe. Carry on.
తెలుగులోనా ఇది ఆర్థరైటిస్ తర్వాత చేయికి ఇంకా సర్జరీ అయింది.
ఆపరేషన్ ముందు ప్రాబ్లం ఏంటమ్మా?
ఆపరేషన్ ముందు షీ కుడ్ నాట్ అంటే లిఫ్ట్ చేయడం ఇంకా మూవ్ చేయడం ఏమీ అవ్వలేదు.
నొప్పి ఎలా ఉండింది?
చాలా పెయిన్ఫుల్ గా ఉండేది. ఇప్పుడు కొంచెం అన్ని మూమెంట్స్ అన్నీ అయ్యి ఇప్పుడు పనులన్నీ తను చేసుకుంటుంది తన పనులు.
ఓకే. आपके कैसा है आपको? आराम है? आप काम कर रहे हैं ना आपकी? ओके, अच्छा है. ओके. कब ऑपरेशन हो गए? 3 महीने हो गए? 1.5 month हो गए. बहुत अच्छा आ गया. Sorry for my juggling of the slides. I'm very sorry, but that's what I wanted to show. Few of my cases, sir.
Thank you, sir. Thank you so much. We got to see a lot of new cases. If anyone has any question, they can ask, or we'll go to the another speaker. After that, we'll take a tea break. Anyone, any questions with regards to this? Okay, now I would like to call Dr. Arun Reddy, sir, to share us his experience of the last year in Continental with some different cases.
నేను చేస్తాను సార్.
We'll have a tea break after this, so be patient. Really interesting cases are coming ahead, so be patient and please. Yes. See, these are not the regular cases. Every case is different, somehow complicated, managed well, so you should know this.
So, yeah, good afternoon, everyone. I think some of you must have known me because I think we all interacted in a previous seminar that happened here. So, like how you have seen, I would say that Dr. Gautam's heart is in the rings, right? He does them very passionately, and Dr. Chekkar's passion is in elbows and shoulders. Similarly, I have my heart in the knees, that's what I would say, because I perform all my simple knees to complex primary to revision knees and hips in a similar each and every case so passionately. Okay, so I'll just present some of the very interesting cases. So this is the button. This is the, yeah. So yeah, so this looks like a simple arthritic knee, right? But can you see a small fracture there? Everybody? So that is when. So I would, whenever a patient comes and asks me, or they'll also ask you, should I get a knee replacement done or not? In 95% of the cases, you are not allowed to suggest a knee replacement because it should be the patient who has to tell the doctor, I'm suffering so bad, then only you have to operate. But only in 5% of cases, and this is one such case, where if you see lot of bowing, somebody is walking on the road with lot of bowing, that means those pillars are in a crooked way and they might break any time, and this is one such case. So what happened, can you see? Somebody said that you just walk around or otherwise we'll just put immobilized in a slab. And what happened? It has gone into a non-union, first a frank fracture and then into complete non-union. So, and she has been lying on the bed for almost an year. And because everybody wants to treat the fracture now, and they are advising conservative management. So, and this is a very difficult case to deal with, and you should have a philosophy, because should you want to treat the fracture first? Because if you treat only the fracture first, the patient is going to lie down for another 6 months. And anything might happen in the 6 months. So you should, so I chose, so you can see how frankly the joint is mobile. If you just give some stress, it's going everywhere. So I have calculated, so these are some technical details. So this is very difficult to do because the proximal fragment is very mobile. It's like a swing, and to take a cut itself is going to be very difficult. So I have used an intramedullary guide, and the jig is from one company, the instruments are from another company, the implants are from one company, and I also put a backup of another implant company people, so that, you know, and this is my first case in Continental Hospital, and such kind of cases wasn't done before, I don't know. So I have treated it with a knee replacement with a long rod and not touch the fracture site. I have just given it a good alignment so that the nature will heal the fracture. I did not open the fracture site, no bone graft, no plating and nothing. And see, within 6 months what happened? It is completely united. I didn't touch the fracture. I just gave the limb its own alignment and it has gone into union. So now let's come to another interesting case. So this is what in every primary surgeon who called simple joint replacement, people are all worried, their knees getting infected. And I think only a surgeon who can deal with his complications, including infected joint replacements and including aseptic loosening, only should be doing the primary replacements. And I don't know why there are only few in Hyderabad who are dealing with revision knees, infected knees, and so that is a problem. So if you don't do your simple primary knee well enough, they are bound to get aseptic loosening within 5 years. I've seen multiple knees and I've revised by myself, and if you don't take proper aseptic precautions while operating, they are going to get infected. And that is where that's why I say my heart is always in the knees and hips. I do each and every simple case so passionately, like how I do a revision knee also. So you can see, so then I had to remove everything what has been implanted by the primary surgeon. The primary surgeon was always doesn't want to deal with it because he doesn't want to do a revision knee, and he was telling use antibiotics and all that. So I have removed, you need special instruments to remove, you can see those all kinds of special things. You can see these special articulating spaces, just like how Dr. Gautam sir has used in the femur, we also have articulating spaces. The beauty of this thing is it will also give antibiotics and the patient can walk on it. Yes. So this is how it is done. And the second stage, once everything is free, we have done this revision TKR stage 2. And this is the first time that the sleeves has been used in a hospital. So very beautifully done with center, everything center. So this is called a sleeve on the tibia side. And all those dots are antibiotic beads which elude antibiotics. So now coming to the case 3. So this is once you can see, so I am holding a navigation. So we have recently are also doing hips using the newest technology called navigated knees, where you can check the alignment with the help of computer navigation, and you can see the result, how beautifully the center, the femur and cup. So you can also do simple knees and hips in a very advanced technological way, giving a personalized custom-made implants to the patient. Because you see, whenever you are referring a patient to your doctor, you are also not referring to him, you are also marrying his philosophy. And that's what. So I generally believe in using advanced technologies which are evidence-based. So this is one such evidence-based technology which we have used in a hospital, the first time in Hyderabad, using the navigated computer navigation to manage primary hips. So this is that thing. Okay, coming to case 4. So this is another case. You can see both his hips damaged totally, and we have performed bilateral hip replacement simultaneously. Okay, and coming to case 5.
1, 2, 3.
It's a radial head fracture. You can see total combination. Broken into 4 pieces.
No quiero separarme de ti, ni siquiera un momento. No quiero perder el tiempo. Sabes que
So that is the result in 2 weeks. So a 55-year-old guy, complete radius, the radius got fractured into 4 pieces. So there is no point in, somebody might even fix it. But that's why I say when you're choosing a surgeon, you're choosing his philosophy too. So there is no point in just fixing it. I just replaced it. And I think that's the second case that has radial head replacement done in the hospital. One was done before. So, and within 2 weeks, he's very happy. That's what he needs, right? No, he has just went on to his work from the 3rd week itself. So coming to the proximal, so this another case which we have recently done. This is a 8-year-old guy with osteosarcoma. So we need to resect such a big proximal, the entire proximal tibia. And you can see the femur there, and below the femur you don't have any bone. So we do something, and this also first case where we have used expandable tumor processes in the hospital. So we have custom made it from Chennai. So we take the CT scans, MRI scans, do all the calculations where to put the screws and all. And I have sent him the design, and they have prepared accordingly. So you can see then have this. So there won't be any jigs in custom made. There won't be any jigs like primary TKR so we have to do it manually. And you can see this is the proximal tumor processes we call it. And as the child grows, we can also increase the length of these processes. So this is one, and after that you can see how the plastic surgeon has neatly covered with muzzle and all the implant. Yeah, so this is the processes. The big one. So this is another case. So along with knee and hip replacements, I am a sports surgeon where I regularly deal with all kinds of ligament injuries around the knee. So in this case, you can see the ACL got avulsed. So, and instead of previously they used to fix with screws and all that, now we are just tying up you can see, I just catch hold of the ACL ligament, got it down and used the endo button. That's a different case and this is a different one. But in this you can see how I am catching hold of the ACL ligament and bringing it down. So if I am pushing it. So with that, the avulsion can be treated without doing any ACL reconstruction. This is just preserving its natural ACL. Bony avulsion. So this is another case of shoulder Though Dr. Chakradhar and Dr. Sudhakar, who is not here, they deal with shoulder rotator cuffs regularly. Also keep doing shoulders now and then. So this is one such simple.
I would never fall in love again until I found her. I said I would never fall unless it's you I fall into. I was lost.
You can see how it's getting elevated.
Darkness, but then I found her. I found you.
So that's such kind of small Skarsgård type 2 fractures will be missed on X-rays. You need to see them neatly elevate and then only fix it. Only then you will get a good outcome. So this is another case where the patient had both an ACL and ACL tear and an MCL tear. I did the ACL reconstruction and did an MCL repair on the same stage. And in this video, you can see how immediately post-operatively, how solid the knee has went on to go.
Can we skip to the good part?
So that's how you can see top is the before surgery and immediately after surgery, how both the Latchman anterior drawer test and also the varus valgus test have been done. Yeah, so I think that's all. Thanks for your patient listening. So just to tell again, the orthopedics department in Continental hospitals is dealing with the most variety of cases. Sometimes such kind of cases which are being rejected everywhere in the city and also sometimes I feel in country also. And we are doing sports injuries, dealing with sports injuries with our excellent physiotherapy team, where there's a lot of sports rehab specific people. And rest assured, you can, whenever you send your patient, loved ones, friends, family, you can be rest assured that we are working as a team. And we always have these team discussions where we discuss on how to approach to a case. Sometimes there are many instances where we transferred case from our care to our colleagues' care when we feel that they are very much efficient in doing this, because each surgeon is different in their own philosophies. And when we think that our colleagues' philosophy is much better to this fracture, we always refer. So, and also thank Dr. Guru sir and Raghu sir, who have always been supporting young talent, who are young new talent in the city. There are only few people who trust in this kind of philosophy, because everybody wants to get a very experienced kind of people. There are only few visionary people who believe in young talent, new technologies, and that's what the world needs, I guess, in every field.
Thank you so much, Dr. Arun sir. As you have seen that we are dealing with a variety of cases, complex traumas, revision joint surgeries, even bone tumors. And we have got all the technologies and all the experience here, and we always go for a multidisciplinary approach. So we will involve neurologists, neurosurgeons, vascular surgeons, plastic surgeon, everyone into this thing to bring out the greatest and the best outcome. So for 10 minutes, we'll have a tea break, then we'll resume with our case presentation. If you have any questions for the speakers, you can ask with regard to any cases presented here or any other query. With respect to rehabilitations,
If any one of your loved ones operated, any problems you want to discuss, any cases you can discuss with us. You have any doubts, you can discuss. Philosophical doubts also will counsel very nicely. I counsel patients very nicely. You know that? Any philosophical doubts also I can clear.
sir, how, in simpler words,
Right, they are eager to go and have a tea.
sir, in simple, like I'll ask the question. Simply like how the patient should decide or how the caretaker of the patient should decide for a joint replacement,
We'll ask one thing, knee osteoarthritis.
knee, hip, any, how they will decide when to decide, like when.
Look, nobody comes to the hospital because it's not a picnic spot, it is a mall or cinema theater. They have a real problem, that's why they come here. There are two ways of dealing with this. One is, when you come to this profession, you should have few qualities like sympathy, empathy, compassion. The minute they come, even you have a pain inside, something is going on, but the way you communicate and the way you look is something different. Do you understand? That's what they used to say in British thing. You need to be in their shoes. Talk to them nicely. The major problem what doctors do is busy. This is what they don't see. Talk to them. Eye to eye contact. Spend time. Some people are introverts, they won't open. Some people are afraid of you, what this fellow is going to tell. Make them calm. Make them peace. Spend time. Talk to them. What is our basic thing in the medical college? History taking. History taking itself, 99% diagnosis there.
Respect to patients, how they will, like
When they see, again, we'll ask few questions. Are you able to sleep? Are you able to do your daily activities? Are you able to walk? Are you able to stand? And another important, suppose there is any function they want to go. Sometimes I'm having pain, I can't go. Those are the things you need to hold it. Then examination, see the x-rays, what patient wants. See, again, categories are different. Suppose I want my sons to get married. But see, our Indians, we sit on the floor and we have to do our rituals. That time, there are other options like giving injections, as Guru Sir said, stem cell therapy or cool-leaf therapy is there where we freeze the nerves. So the 2 years it will get benefited. When you do this, you need to tell patients not to climb stairs, not to sit down, not to lift the weights. Climbing stairs also reduce. Another important thing is when the patient comes, you need to see the BMI, their height and their weight. If I am 120 kgs, I am supposed to be at 80 kgs, then where is the weight is going through? Through the knees. Until unless you don't tackle the primary problem, you are beating around the bush and you are not hitting the bush. That's all. Yes, sir.
We're not going to hold the tea, but just one thing, just an advice to the physiotherapists here. You know, most of you are very young and you're kind of planning for your career. My advice is that as you're going through your school, choose in what area of physiotherapy that you want to specialize. There are general physiotherapists, but I'll recommend strongly, choose a particular specialty. The opportunity is very immense. And just look at, for example, orthopedics. Now, you have seen the wonderful presentations of all the 3 orthopedic surgeons just now. But post-op care is all about physiotherapy. Physiotherapy is so extremely important. And it is so gratifying. You truly kind of, become a part of the journey of the patient, and they trust in you. You're the liaisoning between the doctor and the patient for the rest of the journey. So there's a tremendous opportunity. Choose good institutions, choose great doctors, and stick to one doctor also. For example, Dr. Gautam, Chakradhar, Dr. Arun, and all were presented. There's a lot of meaning because you'll understand what are the techniques these doctors are employing, what is the philosophy in terms of recovery, and there's enough money to be made. Now, today's world, physiotherapy has become, number one is by giving the prefix as a doctor, and you guys are in a different cloud, and you'll be called as a doctor, and then you're taking your little ultrasonic or machines and whatever that you need to do and collect per hour. It has become like some retail business. Don't get trapped into that. Young India, 1.4 billion people. There'll be tremendous growth in terms of healthcare needs. So when you're starting this is advice I want to share with you. You make your profession very worthy, and whatever you're getting trained, make it purposeful, and try to align with one doctor or with a group, and take your journey forward. Then a lot of patients will come to consult with you. On that note, I want to inform you that Continental will have the largest rehabilitation unit in the twin states of Andhra and Telangana, which is being built on a 7th floor, which completely with inpatient rehab rooms, with a very large outpatient area, with a sunken swimming pool, all the latest gadgets for neuro rehab, for ortho rehab, for cardio rehab. So this will be one of the largest in the two twin states, probably in the South India, dedicated to, that will be completed by December. And there will be a lot of physiotherapists. Dr. Srinivas Reddy, who is heading a physiotherapy department, an opportunity at this place. Thank you all.
Thank you, sir. Thank you.
Generally, the physiotherapists are attached to orthopedic group. And the exercises that you do, if a GI patient is operated or like any other patient is operated, is by and large the same. I think as doctor has suggested, there should be more specialists assigned in the physiotherapy
Absolutely.
department.
Musculoskeletal.
I have seen virtually physiotherapists going and doing and about this patient, moving this and next.
So this is an awakening for me after probably this is the only conference of orthopedics that I participate. I know the best of the orthopedic surgeons from my career back in the US. I always had great respect for them. But something when I'm sitting there, I'm trying to think about this. And Srinivas Reddy, I think it is time, to really pick and cull and some of the good physiotherapists attached to them, if necessarily every 6 months rotate, truly. I think so they are true and true dedicated, just like a physician assistant. They will be with the doctor and they'll take care of them. That's my way.
Absolutely.
Indian, they are already started as per the who are the specialized in neuro, ortho, and even gynec also. They have the specialized team that will improve.
Thank you.
Sir, Ajay, sir. Outside, sir.
We are thankful to our patients who have come all over from different places just to share their stories with you. Thank you, sir. Any more questions? Sir, you always tell the BMI and weight losing, but whenever the patients are having lower limb problems, how they are supposed to lose weight? Any tips on that?
See, losing weight is important, but you need to find out why you are putting on weight. It could be metabolic. People having thyroid, they put on weight. And genetically, some people put on weight. And some people binge eating, they put on weight. So you need to find out what is the problem. Then you deal the problem. But I think before coming to middle age, nobody will put while studying and while working. Once the problem, where is the weight putting? Marriage. The minute wedding starts, both will get together, go and eat everywhere and put on weight. So the best way of losing weight is zip the mouth. You will lose the weight. Next question. Anything else?
So our physio friends always deal with you always deal with sports injuries. Do you have any queries on that? I was about to ask how to, people may be knowing how to diagnose different ligament and soft tissue injuries, but when to refer and when to get an arthroscopic or an MRI done is most important. Any questions regarding with that? Okay. So So we'll continue with the session. I'll call upon our another speaker, Dr. Arun Reddy sir. Yeah, Dr. Charan Reddy sir. He's on behalf of Dr. Sudhakar Reddy sir. He's as Guru sir have already told, he's celebrating his 50th birthday. So his colleague Dr. Charan Reddy sir will be discussing or presenting some interesting cases. Sir. Tea break, they are having tea, no? Okay. See, they will be serving the tea on your place, so we'll continue with the session. Okay, or you want a break? We'll continue. Okay, we'll no, they are comfortable. Okay.
This one, sir. Break.
Okay, we'll take 10 minutes break. Okay? You can use that break and we'll resume after 10 minutes.
Welcome back, everyone. I'm Dr. Charan. I'm presenting the cases on behalf of Dr. Sudhakar Reddy. So, very good afternoon. So, I'll start with the trauma cases, then I'll go to the plasty and followed by arthroscopy. So, the first case is a 42-year-old female who met with a road traffic accident. She was a teacher. She was going on a two-wheeler and was hit by a truck. So, she sustained massive soft tissue injury to the right upper limb. She was taken to a local hospital where they advised for amputation, but the patient was not willing for above elbow amputation, and she came here for the limb preservation surgery. So you can see extensive degloving of the soft tissues, and she sustained fracture ulna and radius also, for which the surgery was done in 3 stages. It was a staged surgery. The first stage we have debrided completely and we have immobilized the bones with 2 square nails. You can see the debride. In the first image you can see the debridement and vac dressing done, followed by after 6 weeks we have done a skin grafting for the complete wound coverage. There was no infection, so we went ahead, and in the third stage we have done the plating and square nailing for the both bones for action. And at the end of 3 months, she achieved full range of movements. And this is another case where a 40-year-old male was admitted with a history of RTA. A tractor was run over him on going on to both knees. So he sustained extensive soft tissue injury along with that comminuted proximal tibia fractures, both sides. So primarily, it was like polytrauma. His vitals were not stable. So to first to stabilize him, we have put the spanning external fixator for both the limbs, stabilized him. Then we have taken him for the staged procedure. In the second stage, we have applied plating for the right proximal tibia where it got infected. So we have taken him for the third stage procedure where we have applied the Elizar O-rings. So once the infection was subsided, the rings were continued until the bony union was achieved. Even the other side, the left side also, as there was extensive soft tissue injury, we could not do plating or nailing, and we went ahead with the Elizar O-ring fixation. You can see the last image. He achieved 90-degree flexion in spite of badly comminuted fracture. He achieved 90 degrees of flexion on both sides. It was even more in the left side, which up till 120 degrees. And right side, as he had osteomyelitis, it was treated later with Elizar O-ring fixation and stimulant application. It took about almost 6 months to recover fully. So patient is now walking full weight bearing on both lower limbs, and he has a knee range of movement in the right side up to 100 degrees and left side up till 120 degrees. So this is also a case of RTA where there was a badly comminuted right proximal humerus where plating was done. So this was one more case of RTA where there was badly comminuted right distal femur fracture was there. As there was gross contamination, so we have taken him for the debridement, followed by definitive fixation with plating. Plating was done. Later, in the second stage, we have done a bone grafting, and post-operatively 6 months later, patient is walking full weight bearing and complete union was achieved. But as there was bone loss, it took more time to heal. And this was a case where the patient had a fall from height and sustained injury to the calcaneum. Patient was not operated immediately, as in the cases of calcaneum, there was a gross swelling which took time of 3 weeks to reduce. So the patient was put on a slab, POP, only the slab, below knee slab application for 3 weeks, treated with rest, ice application and compressions. And once the swelling was subsided, we have taken him for definitive fixation. So we have put on the plate for the calcaneum fixation. Most of the calcaneum cases are being treated conservatively, but if there is a displacement like this, definitely it has to be fixed, because young patients, if you are not fixing it, it might lead to malunion and there will be a persistent pain and there will be swelling. So it has to be fixed. So this was the plating which we have done, and this is the X-ray post-operatively after 6 months where he started walking and full weight bearing. And coming to the plastic periprosthetic fractures, she was a 6 months old post-op case of TKR where she had a fall in the home and sustained right supracondylar femur fracture. So this case was taken up and plating was done like this. So post-operatively, after 4 months, she was walking full weight bearing with complete range of movements as in immediate post-TKR cases. So this was a very interesting case. She was 101-year-old female who had a self fall. So she was a very high risk case for surgery, but in spite of that, we went ahead and we have fixed it. So this was the immediate post-op X-ray, and so 4 months post-op, she was walking full weight bearing. She was a very high risk case. She was taken up at death on table, but any fracture, this is a fracture of necessity which has to be fixed. Now she was even able to walk without walker, but we have advised her the walker as a prevention for further falls and further injuries. This patient came all the way from Chhattisgarh. She was having avascular necrosis of the right femoral head along with the secondary osteoarthritis. So initially patient was reluctant. Since last 5 years, she was having home remedies and Ayurvedic treatment. In spite of that, she was not having any improvement. So she came here for the joint replacement. This was the initial X-ray, and she was walking like this. She was almost bedridden. She was only able to walk with the help of the support. And this was the immediate post-op X-ray, and 4 days post-op she was walking like this. Even her limb length discrepancy was corrected. This was a case operated just a week ago. And she is a case international patient. She came all the way from Cameroon to get operated. She had a bad valgus knee. Even there were contractures. Along with valgus, she had some fixed flexion deformity. And she was almost coming in wheelchair. She was not able to walk. So post-surgery, her deformity was corrected and she is able to bend her knees and walk properly. And valgus with FFDs, this is one of the rare findings. So this was one of the interesting cases. And this patient, the patient had a history of trauma. He was having DRUJ instability. Along with that, he had a history, since DRUJ instability, distal radial ulnar joint near the wrist, he had pain and restriction of the movements. But he had a history of fall, following which he has pain and restriction of movements of the wrist. So he came to the hospital mainly for the pain. When we examined him, he had a DRUJ instability since childhood itself. So we have taken him for surgery. You can see the instability. The ulna was moving. You can see the marking over there. Normally, the tip of the radial styloid should be 1.5 centimeters from the level of ulnar styloid. So, but in this case of ulnar negative variance, ulnar positive variance, the articular surface of the radius is about 1 centimeter below the ulna. So we have to correct it. The both should be at the same level. So we have done an osteotomy, reduce the length of the ulna so that there will be ulnar neutral variance. You can see This was the osteotomy done. We have removed about 1.5 centimeters of the bone to correct the variance, ulnar positive variance. So this was the post-op X-ray. After correcting the ulnar variance, there was still instability. The distal radial ulnar joint was mobilized. So we have fixed it with the mini tightrope. You can see here too. These are the tightrope which we fixed it. And the osteotomy site was fixed with plating, ulnar plating. This was a case of massive rotator cuff test where even the physiotherapists do commonly come across this type of cases with shoulder pain and weakness. When there is a massive cuff retraction, if it is mild, it will be less than 2 centimeters, moderate 2 to 5. Whereas in case of massive cuff retractions more than 5 centimeters, the patient was advised for reverse shoulder arthroplasty in one of the corporates. She juggled from hospital to hospital. Patient was advised only for reverse shoulder, but she came here. She was not willing for an arthroplasty. So we have gone ahead and done speed bridge with Scopy. We have repaired the rotator cuff. Following which, this is the 2 months post-op. Patient has fully recovered and he was doing well. See, even when the cuff quality is good and the cuff is entirely coming to the footprint, there is no need of reverse shoulder arthroplasty. We can go ahead and fix it with the Scopy itself, okay? So most of these cases commonly seen by physiotherapists where the cuff retraction more than 5 centimeters doesn't necessarily require a reverse shoulder arthroplasty. We can give it a try. We can try once for fixation if the cuff quality is good and the patient patient should have proper deltoid muscle contractions, everything. So this was another case where the patient was a police constable and he was having recurrent shoulder dislocations for the past 3 years. Even while sleeping with his hand under the head, he was dislocating his elbow. So when the MRI was done, he was having a labral tear, and along with that, he was having a Hill-Sachs lesion. There was some posterolateral area in the femoral head. There was some bone loss. So we have to address both the problems. So we went ahead and fixed the labral repair. You can see this was the labrum, a bit difficult to understand, but this was the labrum here, which was reattached with the suture anchors. And even there was a remplissage. The posterolateral bone defect was filled up with the soft tissue, so that it was a two-way procedure to stabilize the shoulder. So patient was even having a difficulty in just moving the shoulder also, and he was very apprehensive. Even while bike riding, he was having a feeling that the shoulder might dislocate. So post-surgery, this was post-surgery around 2 months. He was a bit aggressive in physio. So he achieved full range of movements and there was complete stability. And he was totally fine. He joined his duties. Post 2 months, he was completely fine with. So even any Bankart repair post-surgery with aggressive physiotherapy, you can join his day-to-day activities, even physical activities at the end of 2 months. And this case, the patient was a 22-year male. He had a history of fall from the train. So he has suffered an extensive injury to the left lower limb where it was amputated. A bony amputation was done. And right lower limb, he had a soft tissue injury over the ankle. So they have treated for the soft tissue injury and there was no bony injury. They have only treated the soft tissue injury with grafting, and they didn't address the contracture problem. So patient was keeping his foot in equinus. In spite of having a normal soft tissue and no bony injury, the patient developed contractures. So this was the position of the ankle when he presented to us. So this could have been actually prevented in the stage 1 only. When they have done the amputation on the other side, right side, if they could have applied POP, this could have been prevented. But they didn't address the problem. So 2 years later, he presented to Continental with this problem. And patient was immobile because there was the one side, a bony amputation was done. The other side, he has equinus. So to mobilize him, we require prosthesis on one side and other limb should be fine. Whereas in this case, there was no chance. So to mobilize him, we have to do, the tender Achilles contracture was there, so we have to release the tender Achilles contracture, and posteriorly the capsule was very tight, so we had to release the posterior capsule. Tenotomy was done for even the flexor tendon, FDL, flexor distorum longus tendon was totally contracted, so we released them. So we have done it as a 3-stage, it was only a soft tissue procedure, nothing like bony, because the bones were entirely normal. So as sir said, Gautam sir said earlier, even the contractures can be corrected with the Ilizaro. So even some hospitals, they advised him to go for the arthrodesis of the ankle, or else even some, they went ahead and they were planning for amputation. So it doesn't require. So post-op with the ring fixation, we corrected the deformity. He achieved the normal ankle. Now he is walking. We have put the process for the other limb also. So he is able to walk normally. This is a case of simple mismanagement at the primary level, which could have been easily prevented by simple slab application for 2 weeks. So it was not addressed. So here we just corrected the soft tissue. He got his full range of movements. Patient is mobilizing happily. This was the Ilizaro ring fixation. You can see we applied like this, corrected the deformity. It was only soft tissue release, and gradually the soft tissue correction was done over a period of 6 weeks. So and at the rate of 1 mm per day, 1 degree, 1 mm is equal to 1 degree. So we achieved this from equinus to normal ankle position in over a period of 6 weeks. Following which we removed that. When we have put a below knee cast, patient was mobilized, full weight bearing, and then the process was attached to the other limb. Okay, thank you. Any doubts?
Hi, good afternoon, everyone. Warm greetings from Continental Hospital. I know all of you must be hungry and tired and sleepy as well. I won't take too much of your time. Today, I would like to predominantly discuss about one potential disastrous case which I could, by God's grace, resurrect. This is a case of complex midfoot Charcot deformity. As I'm sure that most people would not have too much of background into what a Charcot deformity is, I would like to kind of give you a brief intro. This is also on lines of what I've said in the grand rounds. All of us know that India is the diabetes capital of the world. Unfortunately, we don't have a good data in terms of Indian healthcare. So I'm using data from the UK. The annual expenditure on diabetes and diabetes-related complications in UK amounts to close to 1 billion, which is 1% of the total NHS budget. And if you look at people who have diabetes, all of them have a cumulative lifetime risk of up to 25% to develop an ulcer. And most of the people who end up with an amputation secondary to diabetes almost have an ulcer preceding that. And also, when you look at the mortality data, 5-year mortality data, you can see here that even in something like breast cancer, you only have 10% mortality rates. But when it comes to Charcot foot or diabetic foot ulcers, you can see that the mortality kind of pops up to 30%. And even when you look at people who've had major amputation, obviously we all know that not all of that is due to post-traumatic causes. A significant chunk of that is secondary to diabetes as well. So this problem has been addressed by all these institutions in UK in 2011, 15, and 16, and they've come up with the comprehensive task force wherein they have kind of developed a 3-tier system. The first tier is a foot protection service, wherein you have the GPs who kind of screen these feet regularly in people with diabetes. And the second system is at a secondary center like a district general hospital where they can deal with ulcers and stuff. But when you get to the really severe deformities, that's where a multidisciplinary foot service like where I work, King's College Hospital comes in, where you have a specialized orthopedic, vascular, and endocrine care. And you have a big multidisciplinary clinic who takes care of these complex deformities. So all of you might be aware of Danavira Surakarna. So, so Karnudi Chowki on the Kara Lena too, there are a lot of causes for the pathophysiology of diabetic foot ulcer and disease. The first one being neuropathy. So when I explain diabetes and diabetes-related complications to my patients, I say that मी रक्तनाल तुप्पु पट्टिनाई. So हिंदी में गंज भर गया है आपके blood vessels में. So as a result of this microangiopathy, even the nerves require blood supply. So the blood supply to the nerves is also affected, which is the reason why you get neuropathy. We all have these really sophisticated suspension system. If you are a car nerd like me, you know that these high-end cars have what is called as a adaptive suspension system, so wherein there is a radar which looks up ahead, scans the potholes on the road, and even before the car reaches the pothole, the car suspension adapts itself. Similarly, we have a radar, which is our eyes, which sends the messages to the foot. Let's say you're walking barefoot on a pebble path, like I showed you in the previous picture. You're walking, your mind automatically adjusts the foot and kind of cushions the landing, which is lost in patients with diabetic neuropathy. So they'll just be banging away at the foot, and you will start developing a lot of these ulcers which you otherwise would not develop. So this is the sensory part of the thing, the sensory neuropathy. Obviously, we also have motor neurons. And when you have motor neuropathy, you have imbalance in the muscles. So normally the foot is supposed to be like this, but when you have an imbalance between the extrinsics and the intrinsics, you develop what is called as a clawing. And you have all the ulcers at the base of the metatarsal heads. Okay. And also, not to forget the autonomic neuropathy, the nerve supply to the sweat glands and the sebaceous glands. If you look at a lot of these diabetic feet, you see that their feet look like a leather coffin. Okay. So, which is also the reason why they do not have the same amount of suppleness. You just need to have one brush against a rough surface, and it's the layer peels off. So, also, as I said earlier, you have rust. You have rusting throughout the body, which is the reason why they develop strokes, they develop cardiovascular incidents, and okay, you have rust in the system, but when you have a larger pipe, you still have blood flow. But as you reach lower, when the pipes get smaller, the rust is going to block the arteries, as a result of which they won't have enough blood supply, and if they have any small ulceration, any small wound, it can potentially be the nidus for a very big infection and a spreading infection as well. Also, we might not be too concentrated or aware of this, but when you have uncontrolled diabetes, you also have impaired immunity because the T cell, even the lymphocytes mobility is quite impaired. Which is also the reason why when I have any surgical case which can wait for surgery, I usually tend to optimize the sugars for a while before I take them up for surgery. Coming to natural history of Charcot, these are the patients who have chronic diabetes, their nerves are short, and it's almost like the body is dropping an atom bomb on itself. It is like a Taliban situation. Any small gunshot here or there is going to destabilize the whole state. So you have a small initial trauma which will irritate the nerves, and it will set off a cycle of destruction of your bones and joints, as a result of which the foot structure is going to absolutely collapse. So what we want to do is to catch these feet before they enter into the collapse phase, as a result of which we need to have a very high index of suspicion. This is a quote from Jean-Marie Charcot, after which the condition is named. He described it beautifully in the late 19th century. And overnight, there is an enormous tumefaction of a member. By member, he means a limb here. Okay, 1 or 2 weeks later, sometimes much sooner, the existence of more or less marked cracking signs may be noted, betraying the alteration of articular surfaces, which at this period is already profound. I couldn't find a better description even to date. Okay, this is one of the cases we had when we were at King's College Hospital. This guy came into the emergency department with a swollen foot. One SHO saw this, he said there's nothing wrong, saw the x-ray, sent him home, x-ray presentation. 10 days later, you can see the foot has collapsed. You can see that the Lisfranc joints have dislocated. This is another case, similar case. So what we want to do is to catch them at this stage, 0 stage. A lot of these cases tend to be misdiagnosed here in our country as cellulitis, treated with antibiotics and stuff, and a few months later you end up with disabling deformities. So this is the kind of clinical examination. We do a thorough neurological and a vascular examination. I'm not going to go too much into details here. The problem with this stage is it's difficult to diagnose because you don't find too many changes on the x-ray. The bloods are misleading. So it is just a strong clinical suspicion. Maybe if you suspect it, you can go for an MRI and you'll see the classic findings of edema around the joints and some starting of destruction. So you have a Hulk mode going on. So you need the Black Widow to come down. The Black Widow here being the total contact cast. These are specialized casts applied by us foot and ankle guys, which will reduce the shear forces and will support the architecture of the foot and prevent it from collapsing. And mind you, during these months until the active acute phase of Charcot is going on, the patient is not allowed to put weight on the limb. So after the collapse, you can have major to minor deformities. In minor deformities where most of the architecture is intact, but you just have a certain area of the foot which is kind of sticking out and causing an ulcer, you just kind of shave off the bone and make sure that you don't mess around too much with the architecture. So this is called as an exhaustectomy. This is what we did in one of cases in UK. This is one of my cases here. This man came all the way from Andhra. He had a chronic non-healing ulcer, lateral midfoot. Since the past 2 years, he was treated by multiple people with antibiotics and whatsoever. So I went ahead and performed an exhaustectomy, and this was the wound at 2 weeks post-op, and with offloading, whack, this is the current status of the wound, which will go on to heal with secondary intention in no time. And yeah. But these kind of pressure relieving measures are not effective in all kinds of cases. In severe deformities, you cannot get away with pressure relieving measures. You have to go ahead with the reconstruction. The conventional wisdom was that these people have poor bone stock, poor bone healing, wound healing issues, ulceration, and that internal fixation always fades. But through trial and error and through sound science, we have people like Jim Samarco, Lou Sean, and following which my professor, Professor Kavartapu himself at King's College Hospital, we've come up with fixation techniques which, mind you, our amputation rates where I used to work were less than 3% over a consistent period of last 7 or 8 years. Also, what we need to understand is the typical patient which we have, the patient is not an Oscar Pistorius. So if you knock off their limb, they're unlikely to get rehabilitated like a post-trauma victim. So which is the reason why we should aim for what is called as functional limb salvage. So this, as I told you earlier, this Charcot zone is like a Taliban war zone or an earthquake zone. So when you have an earthquake zone, you need a more reinforced building structure. So what we have learned through research and years of trial and error is that we need to have what is called as a durable long segment rigid fixation with an optimal bony apposition. In short, we call it a super construct. So these were some of the examples of the earlier construct. This is not quite the super construct. The one at the bottom right corner is what we do right now. So now coming to the case proper, this Beauty and the Beast kind of a scenario here. So this was a 62-year-old gentleman from near Srikakulam. He went out for a daily morning walk. He did not even twist the foot, but apparently had a swollen foot, went to the local doctor. There was some early changes there. If you see, probably you can see that the metatarsus are not lining up at the CMC joints, the TMT joints. But then he was sent away saying that there's nothing wrong with him. And this is months later. He has a massive midfoot collapse, ending up in a disastrous deformity. Fortunately, by the time he came to us, he did not develop any ulcer or infection. So that was a good point where I could catch him. So this is how his foot looked on the day he came to see me. And this is how do I play the video? So I don't know if you might be able to appreciate, which is the reason I have the model here. He has a three-dimensional foot deformity. His midfoot, in the lateral view, his midfoot is collapsed this way. If you look at it this way, these are all subluxed up here, and there is also rotation. So the problem with this case is normally when you have a sharper foot, you have a lot of bony dissolution and disruption, and you have like a blob of bone, which I can make bone cuts and just adjust it. But here the bones were not dissolved. Each bone was still discrete, but it was dislocated in a different direction, which made this job infinitely more difficult for me. Because even for an isolated joint fusion, you always have a failure rate of close to 10%. And here I'm fusing like 5-6 joints at once, so you can imagine the kind of complexity. So I sent the pictures to my colleagues, my professor back in the UK, and you can see that the message at the bottom. So that's what they said. But anyway, I was lucky in this case because he still had good vascularity. And with my experience, I know that once he has a good vascularity, I can still take him up for a major reconstruction. So these were the markings, my surgical markings. Because it is a distorted foot, you need to mark out your arteries, because the arteries do not lie in a normal position. They'll be subluxed. If you do not mark out your arteries before you put your incision, you'll be pinging one of those things, and then you'll end up with vascular complications. So this is the super construct which I did. You can see that the architecture is beautifully restored. This was immediate post-op. This is the current picture of the foot. So this is the transformation from the beast to the beauty. I've started weight bearing him now. I've grown the balls to do it. So right now he's walking in a total contact cast. Tomorrow he's going to come to transition from a total contact cast to a crow walker boot. And at the end of 1 year, he'll go into a bespoke footwear. The road has not been so smooth sailing. I've had quite a little bit of wound complications. You have to do a lot of tender loving care and do some regular dressings for the first 6 weeks or so. And yeah, this is another example of how diabetic foot ulcers, they can look quite benign here. So this is one of the ICU patients here. He had a chronic non-healing ulcer, which was probing down to the bone. But when you look intra-op, you can see that there was a lot of infection on the inside. So we had to totally open up the cavity and debride it. And afterwards, this is at the end of like 6 to 8 weeks with you. I would like to pay my regards to Dr. Vijay Aldandi, who really supports me in terms of antibiotic regimen, and also my plastic surgery colleague, Dr. Raghuveer Reddy, who gives me sound advice. Also, before I joined, I've always been very passionate about foot and ankle. Even before I did my foot and ankle training, I was an SR in Gandhi Medical College from 2017 to 18, and I treated single-handedly 60 patients myself. I'm just showing you an example of this. Is a 9-year-old child, lives near Gulf Bakery, Boinpalli, untreated clubfoot. It took me 6 months to treat him with Ponsity method. and this was at the end of 6 months. On day one, I told him that if he was a little bit of a glutton, you can see he was a fat child. He was fond of biryani. I told him that I'm going to gift you biryani if you let me treat you properly. And he got a massive jumbo biryani at the end of it. So this is another case. This is a chap, he's a dermatology PG in Warangal. He was running out of a train and landed on the platform and sustained this fracture. So I went ahead and did an MIS kind of fixation with a sinus tarsi approach. He's doing very well right now. He has excellent subtalar range of movement. So I presented this, I showed my midfoot Charcot case to the folks at IFAS last month, which led to them inviting me to the first ever SICOT IFAS meeting next week. And I'm going to present on midfoot Charcot principles there in Jaipur. That's all, folks.
Thank you so much, Varun sir. Now foot and ankle. You must have realized that it's not all about major bone fractures and everything. Small things are most difficult to treat. Regarding clubfoot, you may always get these young child infants with clubfoot deformities.
That one I didn't use. Actually, he was unaffordable. So he came for regular dressings and we didn't use WAC. Thankfully, it has healed well. The WAC would have accelerated the recovery, but they were not affordable. Yes, ma'am. I mean, most of the times we get cases with like small ulcers, small toe ulcers. So I do not, and all of these guys have some kind of precursor deformities like clawing and stuff. So we do outpatient-based procedures like tenotomies and stuff, which can be done in. Fortunately, because their nerves are short, they don't feel the pain. I don't need to take them to the operation theater always. I can do a lot of stuff. Even Achilles tenotomies, I do it in the clinic procedure room a lot of times. And when they have clawing and everything, we can do what are called as flexor tenotomies, which also can be done on outpatient base. And I usually always I assess their weight bearing and see what deformities they have, and based on that I talk to our orthotist Shashikant, who keeps in touch with me to get them a custom footwear made so that they don't have recurrence of these kind of ulcers. And not only in diabetics, we see a lot of even relatively normal people who have these muscle imbalances and foot deformities which are not really picked up. Recently I had a trainer, she had a cavus foot. Now we all know about flat foot, but she has a arch feet naturally, a pretty significant deformity at that. And she's been having a very bad knee pain and patella issues because of that. And her issues were never picked up earlier. And apparently I was the first guy to have said that you have a cavus foot and this is the upstream effect of that. So she was quite happy with the kind of assessment.
Thank you, Varun sir. Now we'll next part of all the speakers have spoken. Now I request Dr. Raghu and Reddy sir, our director of Continental Hospital, to give away the mementos to our consultants in orthopedics, the speakers. I'll call them. Please. I call Dr. Gautam Chaudhary, sir, to get.
Good afternoon. I think in a span of about 6 weeks, 60% of you are back in the very same hall. We had the physiotherapy workshop 6 weeks ago. How many of you are participating for the second time? Can you raise your hands here? Okay. In fact, we had an overwhelming response for the first workshop and now also, but we have to restrict this to about 70 to 80 of you. Probably a couple of months down the road, our head of physiotherapy said he will organize one more workshop. Well, ladies and gentlemen, it was truly an amazing journey of the orthopedic team. Continental, right from its inception on 25th of March 2013 till September 30th, 2022, had a team who were constituted in the very first month when we started the journey. It was an excellent team. There was a team first of about 2 consultants, then about 2 more have joined, and orthopedic and joint replacement was one of the #1 departments for about 9 years at Continental. The journey started. The hospital infrastructure was brilliant. The doctors lived up to their expectations, but 70 to 80% in that 9 years period was basically knee replacements, hip replacements, and things like that. When people wanted to leave for various reasons, everyone thought that this department of orthopedics and joint replacement will collapse. Oh, one of the best department doctors are exiting en bloc for some petty considerations in some other places. Many have expressed, the doctors themselves have expressed, some of the colleagues have expressed, and a thing has been created outside that this department, which was numero uno at Continental, will not be there. We started by first recruiting this young orthopedic surgeon, Dr. Arun Mallu. I always felt when we spot somebody, instead of moving from hospital to hospital, you guys should, at a young age, be focused in a given center where you'll be building up the base. He joined in the month of July. He started picking up the threads slowly, which was to the discomfort of the other colleagues. And then we thought, time has come for a change. Then my second interaction, myself and Dr. Reddy interacted with Dr. Gautam. He was always exuberant. He repeated his few of the procedures that he is very good at it. It went above my head, but Dr. Reddy could understand what it is so. Then we had his good friend, wherein he said, sir, he's my good friend, Dr. Chakradhar, who is excellent in the upper arms, shoulder and other things. And then lastly, we had Dr. Sudhakar Reddy. All these 3 out of 4 doctors were in London for 15 years. And then we had Dr. Varun, which this hospital was looking for somebody who's so well trained in ankle and foot. Believe me, in this last 1 year, I was looking at the title of today's thing this morning, reimagining the journey of 1 year. They have simply added, compared to the previous financial year, 1,500 IP admissions, 15,000 OPD patients, and 1,550 surgeries. What is the beauty of this orthopedic surgeons at Continental? This did not constitute a mechanically done cottage industry type knee replacements, 75% of these 1,500 surgeries were complex orthopedic surgeries, out of which 50% landed up at the emergency room of the hospital. These doctors were available at any time. There are several instances in this last 1 year, whether it is Gautam, Arun, or Chakradhar, or Sudhakar, but mostly these two consultants, I used to see them. If a patient is there in the emergency room at 7:30 or 8 o'clock, they used to take the patient into the operation theater, and sometimes the whole night they used to put that in place. You're all budding physiotherapists. I urge upon you, if you come across in your journey or when you start practicing, I don't force or compel you, but truly this orthopedic team, led by these brilliant orthopedicians at Continental, are phenomenal. Whichever part of the human body, whether it is the lower knees or the shoulders or anything. I have virtually seen, Gautam, people breaking the pelvic bones and other things broken into 12 to 13 parts. The coolness with which he counsels the patient and says that, don't worry about it. Continental has now learned the art of doing these surgeries within few hours after the patient is admitted, independent of whether it is a Sunday or a public holiday. Whether the surgery takes about 1 hour or 6 hours, orthopedic surgeons are there to do these complex surgeries. I think many of you in these last 3 years might have run through an array of brilliant procedures done by every consultant, as only few of them out of 1,500 surgeries, these 5 orthopedic surgeons have done in this last 1 year. They could portray only 20 of them, but if there would have been time, they could have showcased many more of such surgeries. So we are there, Continental is there at any given hour, a brilliant orthopedic team which is available 24/7, 7 days a week, however it may be, whatever may be the thing. I am the first to see these patients when they come from Cameroon and other countries. I wonder to myself, how do these doctors change those hands? I keep seeing these guys because I am the first to receive them when they come to the hospital. Either the hands are like this, the legs are like this, but it is amazing to see what kind of corrections are being done and how they have been put back to their daily lives and take it from there. Thank you one and all for this thing.
Thank you, Raghu sir, for those inspiring words. Now I would like to call upon our speakers to collect their mementos from Dr. Raghu Reddy sir. First, Dr. Gautam sir. As you may have noticed, Dr. Gautam sir deals with complex traumas and Elizaro reconstruction surgeries. He is very passionate about those surgeries and taking care of his patients. Thank you, sir. Thank you so much. Next, I would like to call Dr. Chakradhar Reddy, sir. Dr. Arun Reddy, sir. The young and dynamic surgeon of Continental Orthopedics Department. He is also a trained robotic knee surgeon, a knee arthroplasty surgeon. Thank you, sir. Next, I would like to call Dr.
One great thing about these orthopedic surgeons, they are always suited and booted so well.
Next, I would like to call Dr. Varun, sir. Foot and ankle specialist, Continental Hospitals. Thank you, Raghu sir. Thank you so much. Now we are towards the end of our session. I would like to call Dr. Krishna sir for presenting vote of thanks.
Good afternoon, I am Dr. Krishna Teja. I am here to propose the vote of thanks. I thank everyone for your active participation and involvement in this look back and celebration of the year gone by for the Department of Orthopedics at Continental Hospitals. I take it as my personal honor to formally propose the vote of thanks on this occasion. Firstly, I would like to thank our chairman, Dr. Guru sir, for his visionary leadership and impetus towards this department, not just in the conceptualization and execution of this workshop, but also for his holistic vision and support towards the Department of Orthopedics. My sincere thanks to our President and Director, Sri Raghu sir, for his relentless support and pursuit of excellence. I would like to place on the record my heartfelt thanks to all the speakers and faculty for the workshop today. I thank you, Dr. Gautam sir, Dr. Chakradhar sir, Dr. Arun sir, Dr. Varun sir, and Dr. Charan for taking your valuable and sharing all the wonderful insights that you did. We have all learned much and have been enriched by our wisdom. My heartfelt thanks to all the various teams that have been working behind the scenes for the success of this program. Operations, IT, F&B, branding, housekeeping, and all other who have directly and indirectly contributed to conduct and success of this program. Finally, my thanks to all the delegates, colleagues, and participants today who are present here. Thank you for your presence and for making this program a grand success. Once again, from the bottom of my heart, to each one of you, my heartful and sincere thanks. Thank you very much.
Thank you, Krishna sir. I would request Dr. Raghu sir, Chakradhar sir is here to present him in the memento. Dr. Chakradhar Reddy sir is a shoulder surgeon here in Continental Hospital. Thank you, sir. Thank you, both of you. I'll request all the delegates to collect their certificates, which will be given on the back side there. Afterwards, we'll have a group photograph here on the stage. We have arranged lunch in the fine dining hall on first floor. So now I declare the session to be over. Thank you. Thank you. Thank you, sir.
Sheikh, hey Sheikh, I never thought, hey Chakri, listen, I never thought he will be such a good anchor. You did very well. Excellent.